Acute glomerulonephritis. What are the common symptoms and how is it diagnosed? A comprehensive overview for medical students, doctors, and other healthcare professionals. Questions and answers. Question: what is acute glomerulonephritis, and how is it characterized? Answer: acute glomerulonephritis is an inflammatory condition of the glomeruli in the kidneys. It's characterized by decreased glomerular filtration rate, GFR, oliguria, hypertension, active urine sediment, and proteinuria, which is rarely in the nephrotic range. Question: how is decreased GFR related to acute glomerulonephritis? Answer: decreased GFR in acute glomerulonephritis reflects a reduction in kidney function. It's a result of inflammation and damage to the glomeruli, leading to impaired filtration of blood. Question: what does oliguria indicate in the context of acute glomerulonephritis? Answer: oliguria, or reduced urine output, in acute glomerulonephritis is a sign of decreased kidney function. It results from a reduced GFR and can be a manifestation of more severe renal impairment. Question: how does hypertension develop in acute glomerulonephritis? Answer: hypertension in acute glomerulonephritis is often related to fluid retention and activation of the renin-angiotensin-aldosterone system. The impaired glomerular function leads to volume overload, contributing to elevated blood pressure. Question: what is meant by active urine sediment in acute glomerulonephritis? Answer: active urine sediment refers to the presence of abnormal elements in the urine, such as red and white blood cells, casts, and possibly renal tubular cells. This finding is indicative of glomerular inflammation. Question: why is proteinuria rarely in the nephrotic range in acute glomerulonephritis? Answer: in acute glomerulonephritis, proteinuria is usually subnephrotic because the primary damage is inflammatory rather than structural. The glomerular basement membrane typically remains relatively intact, limiting the loss of large proteins like albumin. Question: how is acute glomerulonephritis diagnosed? Answer: acute glomerulonephritis is diagnosed through a combination of clinical assessment, laboratory tests including urinalysis, serology, and kidney biopsy if necessary. The presence of the described findings is crucial for the diagnosis. Question: what is the typical management for acute glomerulonephritis? Answer: management of acute glomerulonephritis often includes supportive care, blood pressure control, dietary modifications, and treatment of the underlying cause, such as infection. Immunosuppressive therapy might be needed in certain cases. Question: what complications can arise from acute glomerulonephritis? Answer: complications of acute glomerulonephritis may include acute kidney injury, chronic kidney disease, hypertensive crisis, and electrolyte imbalances. Question: how is patient prognosis determined in acute glomerulonephritis? Answer: prognosis in acute glomerulonephritis depends on the underlying cause, severity, early diagnosis, appropriate treatment, and patient's overall health. Some cases may resolve completely, while others might progress to chronic kidney disease. Further information. For a comprehensive understanding of acute glomerulonephritis, including its pathophysiology, diagnosis, management, and long-term implications, students and professionals are encouraged to consult nephrology textbooks, current clinical guidelines, and peer-reviewed research articles.
What are the symptoms of acute intermittent porphyria? Definition of acute intermittent porphyria. Acute intermittent porphyria, AIP, is a rare metabolic disorder caused by a partial deficiency in the enzyme hydroxymethylbilane synthase, also known as porphobilinogen deaminase. This enzyme is essential for heme synthesis, and its deficiency results in an accumulation of porphyrin precursors. Specifically, this enzyme catalyzes the conversion of porphobilinogen to hydroxymethylbilane, a key step in heme biosynthesis. Neurologic symptoms of acute intermittent porphyria. Patients may experience peripheral neuropathy manifesting as tingling, numbness, or burning sensation in the extremities. In severe cases, motor neuropathy can lead to muscle weakness or even paralysis. Mental status changes such as anxiety, confusion, or hallucinations may also occur. Identification of AIP in patients with abdominal pain. For patients presenting with severe abdominal pain and neurological symptoms, AIP should be considered. Any recent changes in medications, hormonal fluctuations, or other potential triggers should be identified through a thorough medical history. Patient presentation scenario of AIP. A 28-year-old female presents with severe abdominal pain, tingling in her hands and feet, and elevated heart rate. She recently began a new medication. Neurological examination reveals mild peripheral neuropathy, increasing suspicion for AIP. Diagnosis and recommended tests for AIP. Urine porphobilinogen, PBG, and urine delta-aminolevulinic acid, ALA levels should be tested immediately. Elevated levels of these metabolites during an acute attack would support a diagnosis of AIP. A complete blood count, CBC, may show nonspecific findings but is often performed as part of the diagnostic workup. Statistics and facts about acute intermittent porphyria. AIP affects between 1 in 10,000 and 1 in 50,000 individuals. Many carriers of the mutated HMBS gene remain asymptomatic. AIP often requires a trigger to manifest symptoms. Treatment often involves intravenous hematin to prevent acute attacks. Find more information at the American Porphyria Foundation and the National Organization for Rare Disorders, where comprehensive information on AIP.
Can you be allergic to water? The patient is a 25-year-old who presents with complaints of itchy hives and a burning sensation after taking a shower. A controlled water test was conducted, where the patient's skin was exposed to tap water for 5 minutes. The test resulted in immediate onset of hives and itching. The concept of being allergic to water may sound implausible, but it's a real medical condition known as aquagenic urticaria. This presentation aims to demystify this rare condition, discussing its symptoms, diagnosis, treatment, and impact on a person's life. What is aquagenic urticaria? Aquagenic urticaria is a hypersensitivity to ions or temperature changes in water, which causes the skin to develop hives when it comes into contact with water. Symptoms include red, itchy hives or rash and burning sensation. Symptoms usually occur after contact with any form of water: rain, shower, pool. Controlled water test is performed to make the diagnosis. In this test, the patient's skin is exposed to water under controlled conditions to observe reactions. A skin prick test is sometimes conducted to rule out other forms of allergies. The exact cause is unknown, but several hypotheses exist. 1. Skin's reaction to ions. Some believe the skin reacts to ions or temperature changes in water. 2. Histamine release. Others speculate that water induces a rapid release of histamine, causing symptoms. Aquagenic urticaria is exceedingly rare, with only a few hundred documented cases worldwide. The condition often develops in puberty but can occur at any age. Studies suggest that females may be more commonly affected than males. It's not just tap water that can cause a reaction. Individuals have reported symptoms after exposure to salt water, chlorinated pools, and even their own sweat. Find more information about aquagenic urticaria on WebMD. What are symptoms of anterior cerebral artery stroke? Patients experiencing an anterior cerebral artery (ACA) stroke often present with a unique set of symptoms that include contralateral weakness affecting the lower extremities more than the upper extremities, cognitive and behavioral changes, and urinary incontinence. Why lower extremities are more affected? The anterior cerebral artery primarily supplies the medial and superior parts of the cerebral hemispheres, including regions responsible for lower limb function. This explains why an ACA stroke disproportionately affects the lower extremities on the opposite side of the body. An ACA stroke typically interrupts the blood supply to the areas of the brain responsible for motor function, particularly the legs and feet. This can lead to contralateral weakness and loss of coordination. Cognitive and behavioral changes can also occur due to the involvement of frontal lobe regions supplied by the ACA. Stroke is the fifth leading cause of death in the United States, affecting about 795,000 people annually. ACA strokes constitute approximately 1–3% of all ischemic strokes. They are less common but are crucial to diagnose and treat early due to their potential to cause lasting disability. Along with standard imaging studies like CT and MRI, functional tests such as gait analysis might be conducted to assess the impact on the lower limbs. Cognitive assessment tests could also be employed to evaluate behavioral and mental status changes. Quick intervention is essential for limiting the impact of an ACA stroke. Treatment could involve thrombolytic therapy, anticoagulant medication, and rehabilitation to restore lost functions. For a deeper understanding of ACA strokes, numerous peer-reviewed articles and comprehensive case studies are available. These provide additional insights into advanced diagnostic measures, treatment options, and long-term outcomes. How does Ascaris lumbricoides infection affect peripheral blood eosinophilia? Historical facts. Ascaris lumbricoides has been recognized for centuries as a cause of intestinal parasitism, with evidence dating back to ancient civilizations. It continues to be a significant public health concern, especially in developing nations. Symptoms. Infected individuals may experience a range of symptoms, from asymptomatic to abdominal pain, bloating, nausea, vomiting, and intestinal obstruction. Pulmonary symptoms like cough and wheezing can occur during the larval migratory phase. Diagnostic considerations. For diagnosis, eosinophilia is often an early indicator but tends to decrease as the parasites mature into adult worms. Confirmation usually involves stool microscopy to identify Ascaris eggs. Other advanced diagnostic methods may include serological tests and imaging studies like ultrasound or CT scans, especially if intestinal obstruction is suspected. Case presentation: eosinophilia in early Ascaris lumbricoides infection. A patient presents with abdominal discomfort, bloating, and elevated peripheral blood eosinophilia. The eosinophilia is noted to be more prominent shortly after ingestion of contaminated food, coinciding with the larval development of Ascaris lumbricoides. In contrast, eosinophilia subsides as the worms reach adulthood. Statistics. Ascaris lumbricoides infections are most prevalent in tropical and subtropical regions, such as sub-Saharan Africa, Latin America, and parts of Asia. Endemic areas. Ascaris lumbricoides is primarily endemic in tropical and subtropical regions, particularly areas with poor sanitation like parts of sub-Saharan Africa, Latin America, South Asia, and Southeast Asia. Where to find more information? For more in-depth information, consult resources like the World Health Organization or Centers for Disease Control and Prevention. Autosomal dominant polycystic kidney disease, ADPKD, associations and implications. An insight for medical students, doctors, and other healthcare professionals. Questions and answers. Question: what organ systems are commonly affected by autosomal dominant polycystic kidney disease besides the kidney? Answer: in addition to the kidney, ADPKD is associated with liver cysts and other abdominal organ cysts, Barry aneurysms at the circle of Willis, mitral valve prolapse, and diverticulosis. Question: how are liver cysts connected to autosomal dominant polycystic kidney disease? Answer: liver cysts are a common extrarenal manifestation of ADPKD. They are fluid-filled sacs that can occur in the liver and are often found in conjunction with kidney cysts in patients with ADPKD. Question: what is the relationship between Barry aneurysms and autosomal dominant polycystic kidney disease? Answer: Barry aneurysms at the circle of Willis are found in a significant percentage of patients with ADPKD. These aneurysms can be life-threatening if ruptured and are considered a critical cerebral manifestation of the disease. Question: how is mitral valve prolapse linked to autosomal dominant polycystic kidney disease? Answer: mitral valve prolapse is a cardiac manifestation of ADPKD. It refers to the bulging of one or both of the mitral valve leaflets into the left atrium during heart contraction, and it's seen more frequently in ADPKD patients compared to the general population. Question: what is the connection between diverticulosis and autosomal dominant polycystic kidney disease? Answer: diverticulosis, or the formation of small pouches in the walls of the colon, is another manifestation of ADPKD. While the exact reason for this association is not fully understood, it adds to the complexity of managing the disease. Question: how are these associated conditions monitored and managed in patients with autosomal dominant polycystic kidney disease? Answer: monitoring and management of these associated conditions involve regular imaging studies, clinical examinations, blood tests, and consultations with specialists. An individualized, multidisciplinary approach is often required to address the varied manifestations of ADPKD. Further information. For an in-depth understanding of autosomal dominant polycystic kidney disease and its multi-system involvement, medical professionals are encouraged to consult advanced nephrology textbooks, peer-reviewed scientific papers, and clinical guidelines provided by reputable nephrology societies and healthcare organizations. How does Ascaris lumbricoides infection affect peripheral blood eosinophilia? Historical facts. Ascaris lumbricoides has been recognized for centuries as a cause of intestinal parasitism, with evidence dating back to ancient civilizations. It continues to be a significant public health concern, especially in developing nations. Symptoms. Infected individuals may experience a range of symptoms, from asymptomatic to abdominal pain, bloating, nausea, vomiting, and intestinal obstruction. Pulmonary symptoms like cough and wheezing can occur during the larval migratory phase. Diagnostic considerations. For diagnosis, eosinophilia is often an early indicator but tends to decrease as the parasites mature into adult worms. Confirmation usually involves stool microscopy to identify Ascaris eggs. Other advanced diagnostic methods may include serological tests and imaging studies like ultrasound or CT scans, especially if intestinal obstruction is suspected. Case presentation: eosinophilia in early Ascaris lumbricoides infection. A patient presents with abdominal discomfort, bloating, and elevated peripheral blood eosinophilia. The eosinophilia is noted to be more prominent shortly after ingestion of contaminated food, coinciding with the larval development of Ascaris lumbricoides. In contrast, eosinophilia subsides as the worms reach adulthood. Statistics. Ascaris lumbricoides infections are most prevalent in tropical and subtropical regions, such as sub-Saharan Africa, Latin America, and parts of Asia. Endemic areas. Ascaris lumbricoides is primarily endemic in tropical and subtropical regions, particularly areas with poor sanitation like parts of sub-Saharan Africa, Latin America, South Asia, and Southeast Asia. Where to find more information? For more in-depth information, consult resources like the World Health Organization or Centers for Disease Control and Prevention. Autosomal dominant polycystic kidney disease, ADPKD, associations and implications. An insight for medical students, doctors, and other healthcare professionals. Questions and answers. Question: what organ systems are commonly affected by autosomal dominant polycystic kidney disease besides the kidney? Answer: in addition to the kidney, ADPKD is associated with liver cysts and other abdominal organ cysts, Barry aneurysms at the circle of Willis, mitral valve prolapse, and diverticulosis. Question: how are liver cysts connected to autosomal dominant polycystic kidney disease? Answer: liver cysts are a common extrarenal manifestation of ADPKD. They are fluid-filled sacs that can occur in the liver and are often found in conjunction with kidney cysts in patients with ADPKD. Question: what is the relationship between Barry aneurysms and autosomal dominant polycystic kidney disease? Answer: Barry aneurysms at the circle of Willis are found in a significant percentage of patients with ADPKD. These aneurysms can be life-threatening if ruptured and are considered a critical cerebral manifestation of the disease. Question: how is mitral valve prolapse linked to autosomal dominant polycystic kidney disease? Answer: mitral valve prolapse is a cardiac manifestation of ADPKD. It refers to the bulging of one or both of the mitral valve leaflets into the left atrium during heart contraction, and it's seen more frequently in ADPKD patients compared to the general population. Question: what is the connection between diverticulosis and autosomal dominant polycystic kidney disease? Answer: diverticulosis, or the formation of small pouches in the walls of the colon, is another manifestation of ADPKD. While the exact reason for this association is not fully understood, it adds to the complexity of managing the disease. Question: how are these associated conditions monitored and managed in patients with autosomal dominant polycystic kidney disease? Answer: monitoring and management of these associated conditions involve regular imaging studies, clinical examinations, blood tests, and consultations with specialists. An individualized, multidisciplinary approach is often required to address the varied manifestations of ADPKD. Further information. For an in-depth understanding of autosomal dominant polycystic kidney disease and its multi-system involvement, medical professionals are encouraged to consult advanced nephrology textbooks, peer-reviewed scientific papers, and clinical guidelines provided by reputable nephrology societies and healthcare organizations. Case study: diagnosing splenic rupture through the balance sign in a 30-year-old trauma patient. Introduction. The balance sign, a key clinical finding in diagnosing splenic rupture, is seen in trauma scenarios, which account for 90% of all splenic injuries. This case study delves into its application in a 30-year-old patient. Patient presentation. A 30-year-old patient presented to the ER after a motor vehicle accident, with acute left upper abdominal pain, a common presentation in 40–50% of splenic rupture cases. Evaluation and findings. 1. Physical examination revealed the balance sign. 2. CT scan confirmed splenic rupture, the third most common organ injury in blunt abdominal trauma. Diagnosis and treatment. 1. Diagnosis: splenic rupture, with a 25% incidence in severe abdominal trauma. 2. Treatment: emergency splenectomy, performed in 20–30% of cases, followed by supportive care. Exam-focused facts. 1. Balance sign, specific to splenic rupture. 2. Clinical presentation: abdominal pain and Care's sign in 40–50% of cases. 3. Diagnosis: CT scan, which has a 95% sensitivity and specificity rate. 4. Treatment: splenectomy, 20–30% of cases, or conservative management. 5. Etiology: trauma, 90%, malignancies, infections. 6. Prognosis: 15% mortality if untreated, 95% survival with prompt surgical intervention. 7. Historical context, named after Charles Alfred Balance. 8. Clinical relevance: vital sign in 10–20% of spleen-injured patients. 9. Differential diagnosis: other intra-abdominal injuries, kidney trauma. Conclusion: recognition of the balance sign is paramount for timely intervention in splenic rupture cases, as reflected by the relevant statistics. Proper diagnosis and treatment contribute to a favorable prognosis. Where to find more info? For more detailed information, consult trauma surgery textbooks, guidelines, and relevant clinical studies. Case study: Diagnosing achalasia through the Beak sign in a 55-year-old patient, a guide to esophageal motor disorders. Introduction. Achalasia is a rare esophageal disorder affecting around 1 in 100,000 individuals annually. This case study explores the diagnosis of achalasia in a 55-year-old patient, specifically highlighting the Beak sign on a barium swallow. Patient presentation: a 55-year-old patient presented with chronic dysphagia, regurgitation, and weight loss over 6 months. Evaluation and findings. 1. Physical examination was normal. 2. Barium swallow revealed the classic Beak sign, a tapering of the distal esophagus. 3. Esophageal manometry confirmed achalasia, with specific findings consistent with type 2 achalasia, most common subtype, accounting for approximately 65% of cases. Treatment. 1. Pneumatic dilation was performed, leading to significant symptom improvement. Exam-focused facts. 1. Achalasia, motor disorder, incidence of 1 in 100,000 per year. 2. Beak sign, pathognomonic feature on barium swallow, seen in over 90% of cases. 3. Symptoms: dysphagia, 90% of patients, regurgitation, 85%, chest pain, weight loss. 4. Diagnosis: barium swallow and esophageal manometry are definitive tests. 5. Treatment options: halar myotomy, 90% success, pneumatic dilation, 70–80% success. 6. Etiology: mainly idiopathic. Chagas disease can cause secondary achalasia. 7. Differential diagnosis: structural and functional esophageal disorders. 8. Prognosis: symptomatic relief achievable, but ongoing management needed. 9. Bird's beak appearance, specific to achalasia, a critical radiological finding. Conclusion: recognizing the Beak sign is key to diagnosing achalasia and providing targeted treatment. The inclusion of relevant statistics enhances the understanding of the disorder's prevalence, diagnostic features, and treatment outcomes. Where to find more info? Refer to gastroenterology textbooks, clinical guidelines, and research articles for detailed insights. Case study: identifying the Beavor sign, paralysis of the lower rectus abdominis in a 40-year-old patient. Introduction. The Beavor sign, characterized by upward displacement of the umbilicus, is indicative of paralysis of the lower rectus abdominis muscle. This case study highlights the clinical presentation and diagnostic significance of the Beavor sign in a 40-year-old patient. Patient presentation: a 40-year-old patient presented with difficulty in abdominal movement and an abnormal position of the umbilicus. Evaluation and findings. 1. Physical examination showed an upward displacement of the umbilicus during trunk flexion. 2. Neurological examination confirmed paralysis of the lower rectus abdominis, consistent with the Beavor sign. Diagnosis and treatment. 1. MRI of the spinal cord revealed a lesion at the T10 level, affecting the nerve supply to the lower rectus abdominis. 2. The patient was referred for physical therapy and rehabilitation. Exam-focused facts. 1. Beevor sign, associated with paralysis of the lower rectus abdominis muscle. 2. Clinical presentation, upward displacement of the umbilicus during trunk flexion. 3. Diagnosis, clinical examination, supported by imaging if a spinal lesion is suspected. 4. Etiology, trauma, spinal cord lesions, muscular dystrophy, e.g., facioscapulohumeral dystrophy. 5. Treatment, physical therapy, rehabilitation, treatment of underlying cause. 6. Differential diagnosis, other neuromuscular disorders affecting the abdominal muscles. 7. Prognosis, varies with underlying cause, rehabilitation can lead to functional improvement. 8. Beevor's historical context, named after British neurologist Charles Edward Beevor. 9. Clinical relevance, important in evaluating spinal cord lesions, especially at the thoracic level. Conclusion: the Beevor sign is an essential clinical finding that helps in diagnosing paralysis of the lower rectus abdominis. Medical students and practitioners must recognize its significance to ensure accurate diagnosis and appropriate care. Where to find more info? Neurology textbooks, clinical neurology journals, and specialized neurology websites are valuable resources for further study. What is Brewer kidney? Brewer kidney occurs due to septicemia and is characterized by one or multiple kidney abscesses that occur with hematologic seeding of bacteria. Case study: diagnosis and workup of a Brewer kidney in the context of septicemia. Background: a middle-aged patient presents with fever, chills, and lower back pain. The patient has recently been diagnosed with septicemia due to a bacterial infection elsewhere in the body. Clinical examination and laboratory findings. Physical examination: fever, chills, and tenderness in the lower back area, near the kidneys. Blood tests. 1. Elevated white blood cell count indicative of an ongoing infection. 2. Positive blood cultures confirming the bacterial cause of the septicemia. Urine tests. Pyuria and bacteriuria are evident, supporting a urinary tract involvement. Imaging. Ultrasound and CT scans reveal one or multiple kidney abscesses. Diagnosis. A diagnosis of Brewer kidney is made, characterized by kidney abscesses occurring due to hematologic seeding of bacteria in the setting of septicemia. Epidemiology and pathophysiology. Brewer kidney, a rare manifestation of septicemia. Brewer kidney occurs when bacteria circulating in the blood lead to the formation of kidney abscesses. Septicemia, a severe bacterial infection affecting the bloodstream, which can lead to complications like Brewer kidney if not properly treated. Historical significance. Brewer kidney was first described in medical literature in the early 20th century as a distinct clinical entity, gaining attention due to its severity and impact on septicemia cases. Prognostic considerations. The presence of Brewer kidney significantly increases the severity of septicemia and requires immediate treatment to avoid irreversible kidney damage and other life-threatening complications. Conclusion: Brewer kidney is an unusual but severe complication of septicemia that necessitates prompt diagnosis and treatment. This case emphasizes the importance of thorough clinical and diagnostic evaluations in septicemic patients to rule out Brewer kidney. Further reading. For an in-depth understanding of Brewer kidney, you may refer to Renal Abscess, Clinical Overview and Treatment Approaches, published in the Journal of Nephrology and Renal Diseases. Another valuable resource is Septicemia and Kidney Abscess, an emerging complication, found in Clinical Microbiology Reviews. What are symptoms of C1 radiculopathy? C1 radiculopathy is a relatively rare condition affecting the first cervical nerve root. Symptoms are usually nonspecific due to the unique function of the C1 nerve, which doesn't innervate muscles or skin directly. Common symptoms may include occipital headaches, pain radiating from the base of the skull, neck stiffness, restricted range of motion in the neck, suboccipital discomfort, pain or tightness in the region below the occiput. The C1 nerve exits between the skull and the first cervical vertebra. It primarily serves as a sensory nerve for the upper cervical region and does not have a motor function like other cervical nerves. This is why motor symptoms like muscle weakness are not typically associated with C1 radiculopathy. Cervical radiculopathy occurs in approximately 83.2 out of every 100,000 people, but the incidence of C1 radiculopathy within that is much lower. Prompt diagnosis can lead to effective management strategies, minimizing long-term effects. Diagnosis of C1 radiculopathy often involves MRI or CT scans to assess nerve compression or irritation. Additional tests may include electromyography, EMG, to evaluate nerve function, although the C1 level is difficult to evaluate via EMG due to its limited motor function. Treatment for C1 radiculopathy is usually conservative, consisting of pain management and physical therapy. Surgical interventions are rarely needed unless there's a significant underlying cause like a tumor or severe trauma affecting the nerve root. For more information, consider diving into peer-reviewed articles, reviews, and case reports that focus on the diagnosis and treatment of C1 radiculopathy. What is C5 nerve impingement? C5 nerve impingement occurs when the C5 nerve root is compressed, often due to cervical disc herniation, spinal stenosis, or bone spurs. Symptoms commonly include neck pain, upper limb weakness, and numbness or tingling in the shoulder and upper arm. A 45-year-old patient presents with neck pain, tingling, and numbness radiating to the shoulder and upper arm but not extending to the thumb. Physical examination reveals deltoid and bicep muscle weakness. Imaging confirms C5 nerve impingement. Clinical pearls. Affected muscles and sensory symptoms. Deltoid and bicep muscle strength may be reduced, leading to diminished biceps reflex. Numbness or tingling occurs in the shoulder and upper arm, but less commonly in the thumb. Pain localization, typically felt in the deltoid region and upper arm. Factors worsening pain, neck extension and lateral rotation can exacerbate symptoms. Raising or using the arm may also induce pain. Comfortable position. The patient may find a flexed neck position or using a soft collar temporarily comforting. Typical course. Most cases improve with conservative treatment within 6 to 12 weeks. Surgery is reserved for persistent or worsening symptoms. Imaging. MRI remains the gold standard for diagnosis. Differential diagnosis. Thoracic outlet syndrome, brachial plexus injury, rotator cuff tear. Red flags. Progressive weakness, numbness, or loss of function necessitate immediate intervention. Management. Corticosteroid injections, physical therapy, and NSAIDs are initial treatments. Surgery, considered for persistent symptoms or neurological deterioration. Diagnostic measures. Electromyography, EMG. Cervical spine MRI. Neurological and reflex examination. Statistics. C5 nerve impingement constitutes a significant proportion of cervical radiculopathies. Surgical interventions have a success rate of 75 to 90%. Further reading. For an in-depth analysis, consult Cervical Radiculopathy in Campbell's Operative Orthopedics. What is C6 nerve impingement and how is it managed? C6 nerve impingement is a condition where the C6 nerve root is compressed, often due to a cervical disc herniation, spinal stenosis, or osteophytes. Symptoms include neck pain, numbness, or tingling that radiates into the thumb and index finger, along with weakness in the biceps and wrist extensor muscles. Case scenario. A 50-year-old patient presents with neck pain and a tingling sensation radiating down the arm to the thumb and index finger. Weakness is noted in the biceps and wrist extensors. Imaging confirms C6 nerve impingement. Clinical pearls. 1. Affected muscles and sensory symptoms, weakness in the biceps and wrist extensor muscles. Numbness and tingling usually extend to the thumb and index finger. 2. Pain localization, generally localized in the lateral forearm, thumb, and index finger. 3. Factors worsening pain, neck movements, particularly extension, and using the arm can exacerbate pain. 4. Comfortable position, keeping the neck in a neutral or slightly flexed position may offer relief. Typical course, most cases resolve with conservative management within 6-12 weeks. Differential diagnosis, carpal tunnel syndrome, peripheral neuropathy, brachial plexus injury. Red flags, progressive weakness, severe pain, and loss of function require immediate attention. Diagnostic measures. Electromyography, EMG. Cervical spine MRI. Nerve conduction studies. Statistics. C6 impingement accounts for a substantial number of cervical radiculopathies. Approximately 80% improve with conservative treatment. Further reading. For more information, consult Cervical Radiculopathy in the Journal of Orthopedic and Sports Physical Therapy. What causes large, cannon, waves in the jugular venous pulse, and what do they look like? Large, cannon, waves in the jugular venous pulse signify atrial contractions against a closed tricuspid valve. They are most commonly seen in AV dissociation, ectopic atrial beats, and junctional or ventricular rhythms. Visually, cannon A waves appear as unusually prominent pulsations in the jugular vein, often noticeably higher than regular venous pulsations. Case scenario: the patient with irregular rhythms and distended neck veins. A 70-year-old patient with a history of atrial fibrillation presents with palpitations and visibly distended neck veins. On further examination, large, cannon, waves are noted in the jugular venous pulse, appearing as significantly elevated and rhythmic distensions of the vein. An EKG shows episodes of AV dissociation. Clinical pearls. 1. Cannon A waves are visually prominent, rhythmic, and appear more elevated than regular A waves in the jugular venous pulse. 2. Large A waves indicate a hemodynamic aberration that necessitates further evaluation, usually echocardiography or invasive hemodynamic monitoring. 3. AV dissociation, where the atria and ventricles beat independently, most frequently results in this phenomenon. 4. Ectopic atrial beats can transiently cause large A waves but are usually less clinically significant. 5. Junctional or ventricular rhythms can also lead to this sign. Immediate rhythm control may be required. Diagnostic measures. EKG is essential for rhythm assessment and potential underlying cardiac pathology. Invasive hemodynamic monitoring may be required for precise characterization. Management. The treatment strategy depends on the underlying etiology. Antiarrhythmics or cardioversion for rhythm abnormalities, for instance. Statistics. Incidence of AV dissociation in the general population is relatively low, occurring in less than 1% of people undergoing EKG. Source: American Heart Journal. Further reading. For a comprehensive understanding, consult Cardiology, an Integrated Approach, or the American Heart Journal. What are the 4 main causes of end-stage renal disease, ESRD, and how can they be prevented? End-stage renal disease, ESRD, is a serious and life-altering condition where the kidneys cease to function adequately, requiring interventions like dialysis or kidney transplantation for survival. Here we will discuss the 4 main causes of ESRD, along with alarming statistics and potential prevention strategies. 4 main causes of end-stage renal disease. Diabetes mellitus, DM. This is the leading cause of ESRD, accounting for 33% of ESRD cases. The toll of poorly managed diabetes on the kidneys can be devastating. The 5-year survival rate for these patients is less than 20%. Prevention. Effective blood sugar control and regular monitoring can slow the progression to ESRD. Essential hypertension, HTN, is the second leading cause of ESRD, accounting for 30% of ESRD cases. Long-standing, uncontrolled high blood pressure can lead to kidney damage over time. Prevention. Lifestyle modifications and antihypertensive medications can help manage blood pressure levels effectively. Glomerulonephritis comes in as the number 3 cause of ESRD, responsible for 15% of ESRD cases. It involves inflammation and damage to the kidney's microscopic filtering units. Prevention. Early diagnosis and treatment with anti-inflammatory medications could help manage glomerulonephritis. Polycystic kidney disease, PKD. This genetic disorder is the 4th most common cause of ESRD and accounts for 5% of ESRD cases. This condition leads to the development of multiple fluid-filled cysts in the kidneys. Prevention. There is no definitive prevention for PKD, but symptom management and regular monitoring can slow disease progression. The 5-year survival rate for end-stage renal disease, particularly for those with diabetes-induced ESRD, is alarmingly low. It is crucial for early diagnosis and intervention to manage these conditions effectively. The overarching message for prevention includes lifestyle changes, effective medication management, and regular medical checkups. These strategies can delay or even prevent the progression to ESRD in high-risk individuals. Further reading. For further details, numerous peer-reviewed articles and medical research publications offer a more in-depth discussion on ESRD, its causes, and prevention strategies. What are the 4 causes of acute pericarditis? Acute pericarditis is characterized by inflammation of the pericardium and can be differentiated by clinical presentation, ECG changes, and further diagnostic tests such as echocardiography. The primary causes include infection, ischemic heart disease, chronic renal failure, and connective tissue diseases. Case scenario: the patient with recent viral infection and now chest pain. A 60-year-old male with a history of a recent Coxsackie virus infection and hypertension comes in with chest pain that changes with position. The ECG shows diffuse ST segment elevation without reciprocal changes. Further workup, including renal function tests, identifies chronic renal failure as an underlying issue. Clinical pearls. The most common viral causes are Coxsackie virus, echovirus, and Epstein-Barr virus. Malignancies such as lung and breast cancer, as well as lymphomas, are potential rare causes of pericarditis and should be ruled out in unexplained cases. Ischemic pericarditis mandates exclusion of acute myocardial infarction via serial troponin measurements. Uremic pericarditis may necessitate dialysis initiation for symptom resolution. In connective tissue diseases like lupus, corticosteroids may be required, but steroids are generally avoided in viral cases to prevent a protracted course. Diagnostic measures. 1. Look for diffuse ST segment elevation on ECG without reciprocal changes. 2. Elevation in CRP and ESR, though nonspecific. These changes support inflammatory etiology. Acute pericarditis management. NSAIDs remain first line for idiopathic or viral pericarditis. Colchicine is beneficial for recurrent or persistent cases. Statistics. Acute pericarditis accounts for about 0.1% of all hospital admissions. Source: European Heart Journal. Further reading. For in-depth understanding, consult Harrison's Principles of Internal Medicine, or the European Heart Journal. Why can't intravenous vancomycin be used for Clostridium difficile colitis? Vancomycin is an antibiotic used to treat a wide range of bacterial infections. It is commonly administered intravenously for systemic infections but is not effective for treating Clostridium difficile colitis when given IV. Intraluminal concentrations. Vancomycin administered intravenously does not reach adequate intraluminal concentrations in the gastrointestinal tract. Vancomycin has to be given orally to ensure sufficient concentrations in the gut for treating Clostridium difficile colitis. Oral vancomycin has been linked with outbreaks of vancomycin-resistant enterococci, VRE. In 2017 in the United States, around 223,900 cases of Clostridium difficile colitis infections were reported in hospitalized patients, resulting at least 12,800 deaths. VRE prevalence. In healthcare settings, around 30% of enterococci infections are resistant to vancomycin. Vancomycin acts by inhibiting bacterial cell wall synthesis. However, when administered intravenously, it fails to reach effective concentrations in the gut lumen, thereby rendering it ineffective for Clostridium difficile colitis infections. Further reading. For a more comprehensive understanding, you may want to read Efficacy of Oral and Intravenous Vancomycin for Treating Clostridium difficile colitis, published in the Journal of Antimicrobial Agents, 2015. Another valuable resource is Vancomycin-Resistant Enterococci, a review of antimicrobial resistance mechanisms and perspectives of human and animal health, found in Microbial Drug Resistance, 2018. What is Lady Windermere's syndrome? Introduction. Lady Windermere's syndrome primarily affects elderly females, leading to lung disease due to non-tuberculous mycobacteria, NTM. It is often observed in those with anatomical chest abnormalities like pectus excavatum or scoliosis. Historical significance. The condition was first described in 1992. It is named after a fictional character, Lady Windermere, who was portrayed as overly proper. This reflects the hypothesis that affected women may voluntarily suppress cough, leading to poor secretion clearance. Pathophysiology. The syndrome occurs due to inefficient clearance of pulmonary secretions. Anatomical factors like pectus excavatum or scoliosis can make individuals more susceptible to non-tuberculous mycobacteria infections. Diagnosis. Clinical diagnosis involves sputum cultures, chest X-rays, and sometimes CT scans. Treatment. The primary treatment is antibiotic therapy, tailored to the particular non-tuberculous mycobacteria species identified. Examples of NTM species. Common non-tuberculous mycobacteria species implicated include Mycobacterium avium complex, MAC, Mycobacterium kansasi, and Mycobacterium abscessus. Clinical pearls. 1. Anatomical abnormalities predispose individuals to the condition. 2. A multi-drug antibiotic regimen is often required for treatment. Statistics. The exact prevalence is unknown, but non-tuberculous mycobacteria infections, in general, are increasing, with cases often seen in elderly females. Lady Windermere syndrome accounts for a significant portion of these non-tuberculous mycobacteria cases. For more information. For a more comprehensive understanding, the book, Pulmonary Nontuberculous Mycobacterial Disease, Prospects for a New Classification, by Cartalia and Olivier is recommended. What is Chiari-Frommel syndrome and why does it occur postpartum? Introduction. Chiari-Frommel syndrome is a rare postpartum condition characterized by sustained lactation and amenorrhea due to a pituitary adenoma causing hyperprolactinemia. Statistics. 1. Prevalence is not well documented due to rarity. 2. Pituitary adenoma make up 10–15% of all intracranial neoplasms. Why postpartum? The condition occurs after childbirth due to disrupted hormonal balance. In this syndrome, a pituitary adenoma leads to persistently elevated prolactin levels. Clinical scenario. A postpartum woman presents 3 months after delivery with ongoing lactation and amenorrhea, despite not breastfeeding. MRI confirms a pituitary adenoma. Mechanism. The adenoma leads to elevated prolactin, disrupting the hypothalamic pituitary gonadal axis and causing symptoms. Diagnosis. 1. Elevated serum prolactin. 2. MRI. Clinical pearls. 1. Rule out other causes of amenorrhea and galactorrhea. Summary. Chiari-Frommel syndrome is a postpartum condition due to a pituitary adenoma that leads to persistent amenorrhea and lactation. Diagnosis is via serum prolactin levels and MRI. For more information for a comprehensive understanding of pituitary disorders including Chiari-Frommel syndrome, The Pituitary, by Shlomo Melmd is a recommended read. What is the connection between factor V Leiden and APC resistance, and how is APC resistance used as a screening test? Answer. Factor V Leiden is a genetic mutation that is responsible for most cases of APC, activated protein C, resistance, leading to an increased risk of blood clotting. It is present in approximately 5% of the Caucasian population. For this reason, a test for APC resistance can be used as a screening method for the presence of factor V Leiden. Facts about factor versus Leiden and APC resistance. Factor V Leiden is the most common inherited thrombophilia, affecting about 1 in 300 to 1 in 1,000 people. APC resistance is typically found in 20–50% of patients with unprovoked venous thromboembolism, VTE. Approximately 95% of individuals with APC resistance carry the factor V Leiden mutation. The APC resistance test is a functional assay that assesses the inactivation of factor V by activated protein C. Individuals with factor V Leiden have a 5-fold increased risk of VTE, though the absolute risk remains low. Confirmatory genetic testing for factor V Leiden is done when APC resistance is detected, especially in high-risk patients. The presence of factor V Leiden is considered in the management and prophylaxis of thrombotic conditions. The knowledge of factor V Leiden status can impact decisions on anticoagulant therapy, particularly in perioperative settings. Testing for APC resistance and factor V Leiden is often guided by patient history, family history of thrombosis, and clinical presentation. Understanding factor V Leiden and its relationship with APC resistance is essential for personalized medicine, and its knowledge is often tested in medical board examinations. Where to find more info? More information can be found in hematology textbooks, guidelines from coagulation societies, and medical journals specializing in coagulation disorders. Online platforms like UpToDate and Medscape may also be helpful. Craving the inedible, a case study on pica and zinc deficiency in pregnancy. Patient presentation. Patient, Jane Doe, 30-year-old female. Chief complaint, Cravings for unusual non-food items, fatigue. History. Patient is a pregnant woman in her second trimester with a history of irregular, heavy menstrual cycles. Physical exam, glossitis and spoon-shaped nails. Lab results. Zinc level, 50 micrograms DL, low. Other labs within normal limits. Zinc deficiency can result from factors like poor diet, malabsorption conditions, certain medications, increased bodily needs during periods like pregnancy, and chronic illnesses. It can also be more prevalent in certain groups such as vegetarians, the elderly, and those with poor socioeconomic status. As for its relationship to pica, the mechanism is not fully understood, but it's hypothesized that mineral deficiencies like zinc deficiency may alter taste and appetite regulation, leading to cravings for non-nutritive substances. Intriguing facts about pica and zinc deficiency. Pica involves the consumption of non-nutritive, non-food substances over a period of at least 1 month. Typical cravings in pica include soil, paper, soap, cloth, hair, string, wool, chalk, talcum powder, paint, gum, and ice. 3. Zinc is essential for multiple biochemical pathways, including immune function and wound healing. Pica can lead to several complications such as intestinal obstruction, parasitic infections, and dental injuries. Pica is often seen in pregnant women, possibly due to increased nutritional requirements. 6. Zinc deficiency can lead to issues such as hair loss, diarrhea, and delayed wound healing. Consuming clay or soil, a behavior considered pica in Western medicine, is socially acceptable in some cultures. Severe zinc deficiency may result in an increased susceptibility to infections. Zinc deficiencies during pregnancy can lead to adverse pregnancy outcomes, including low birth weight and preterm delivery. Diagnostic criteria for pica require that the behavior is inappropriate for the individual's developmental level. Addressing zinc deficiency often resolves the pica behavior. Pica can sometimes be a symptom of underlying psychological conditions like OCD or autism. Pica isn't confined to humans, it's observed in other animals, particularly domesticated animals like dogs. Summary. Our patient, Jane, exhibits a clear case of pica related to zinc deficiency, likely exacerbated by her pregnancy and history of heavy menstrual cycles. Treatment focused on addressing the zinc deficiency should alleviate her symptoms of pica and improve her overall health. Further information. For more information about pica and zinc deficiency, consult authoritative medical databases, peer-reviewed journals, or the Centers for Disease Control and Prevention, CDC, and World Health Organization, WHO, websites. What is dengue fever? Dengue fever is a mosquito-borne viral illness predominantly transmitted by Aedes aegypti mosquitoes. It has been a known disease for more than 200 years. The term, dengue, is derived from the Swahili phrase, ka dinga pipo, which describes a sudden, cramp-like seizure caused by an evil spirit. The Spanish likely adapted it to dengue, associating the severe joint pain experienced during the illness as a dandy movement. Dengue fever is caused by the dengue virus, which has 4 serotypes: DENV1, DENV2, DENV3, DENV4. The symptoms can range from mild to severe and can escalate into dengue hemorrhagic fever, DHF, or dengue shock syndrome, DSS, in serious cases. Common symptoms include high fever, severe headache, pain behind the eyes, joint and muscle pain, nausea, and rash. Diagnostic tests usually involve blood tests to check for the presence of the virus or its antibodies. Globally, an estimated 400 million dengue infections occur each year. According to the World Health Organization, roughly half of the world's population is at risk for dengue infection. Prevention mainly focuses on mosquito control methods, such as using insect repellents, wearing long sleeves and pants, and utilizing bed nets. A vaccine, Dengivaxia, is available but has limited usage due to age and population restrictions. For more in-depth knowledge about dengue fever, including its complications and preventive measures, scholarly articles and research papers can be accessed through medical databases. What are the differences between the 4 main types of malaria? Differentiation between the 4 main types of malaria, Plasmodium falciparum, Plasmodium vivax, Plasmodium malariae, and Plasmodium ovale, is critical for effective diagnosis and treatment. Each type presents its own unique set of clinical and diagnostic features. Statistics. Plasmodium falciparum accounts for approximately 50% of all malaria cases worldwide. Plasmodium vivax is predominant in the Americas, representing about 74% of cases in the region. Plasmodium malariae and Plasmodium ovale are less common, contributing to around 2% and 1% of cases, respectively. Plasmodium falciparum. This species causes severe malaria and is linked with risks such as multiple organ failure. It accounts for the majority of malaria-related deaths. Diagnosis often involves ring form, trophozoites in a blood smear. Plasmodium vivax, known for causing relapsing malaria due to dormant liver stages, the symptoms are generally mild to moderate. Diagnosis frequently involves identifying Schaffner's dots in infected red blood cells. Plasmodium malariae. This type results in a milder form of the disease, characterized by a quartan fever that recurs every 72 hours. It's diagnosed by the presence of band-form, trophozoites. Plasmodium ovale, also causing relapsing malaria, this type presents with milder symptoms. Diagnosis includes identifying oval-shaped infected red blood cells. Diagnostic methods. Various diagnostic methods are available, such as microscopic examination of blood smears and polymerase chain reaction, PCR, for accurate species identification. Further reading. For those interested in more in-depth knowledge, medical textbooks and scholarly articles offer comprehensive information on each species' clinical and diagnostic features. What are the ECG findings in hypercalcemia? Hypercalcemia is a condition characterized by elevated levels of calcium in the blood. This electrolyte imbalance can have significant effects on cardiac electrical activity, which can be detected on an electrocardiogram, ECG. Common ECG findings in hypercalcemia. Shortened QT interval. The normal QT interval ranges from 0.1 to 0.20 seconds, but in hypercalcemia, this interval is shortened. Absence of ST segment. The ST segment, usually present between the QRS complex and the T wave, is often absent. Early peak of T waves. The T waves, which represent ventricular repolarization, peak earlier than normal. Gradually descending T waves. Unlike the normal sharp descent, the T waves in hypercalcemia descend more gradually. Hypercalcemia affects approximately 0.2% to 1% of the general population. Accurate diagnosis through ECG and serum calcium levels is crucial for appropriate management. Clinical scenario: a 60-year-old patient presents with confusion, fatigue, muscle weakness, and recent episodes of confusion. ECG reveals a shortened QT interval, absence of the ST segment, early peak of T waves, and gradually descending T waves. Subsequent blood tests confirm elevated calcium levels. The ECG findings coupled with the serum calcium test results immediately indicate hypercalcemia, guiding prompt management. Further reading. For more information on the clinical implications of ECG changes in hypercalcemia, consult articles like ECG Abnormalities in Hypercalcemia, a review, which elaborates on the pathophysiology and diagnosis of this condition. When the immune response turns against U.S. immune complexes in bacterial endocarditis, a case study for medical students. Introduction. Bacterial endocarditis can lead to a wide range of complications, including glomerulonephritis, arteritis, and mucocutaneous manifestations. This case study examines a patient with bacterial endocarditis, highlighting the role of circulating immune complexes due to high levels of antibody titers. Patient presentation. A 65-year-old patient was admitted with fever, new heart murmur, petechial rash, and signs of kidney injury. Evaluation and findings. 1. Blood cultures were positive for Streptococcus viridans. 2. Echocardiogram revealed vegetations on a mitral valve. 3. Urinalysis indicated hematuria and proteinuria. 4. Serum showed high levels of antibody titers against the infecting organism, with circulating immune complexes. Treatment. 1. Intravenous antibiotics were administered according to culture sensitivity. 2. Supportive care for renal function and monitoring for systemic complications. Focused facts. 1. Bacterial endocarditis. Inflammation of the endocardium, typically due to infection. 2. Immune complexes. Formation of antigen-antibody complexes can cause glomerulonephritis, arteritis, and mucocutaneous manifestations. 3. Osler's nodes and Janeway lesions. Mucocutaneous signs associated with immune complex deposition. 4. Glomerulonephritis, kidney injury due to immune complex deposition in the glomeruli. 5. Diagnosis, blood cultures, echocardiogram, urinalysis, and serology for circulating immune complexes. 6. Duke criteria, a set of clinical criteria used to diagnose infective endocarditis. 7. Treatment, targeted antibiotic therapy, possible surgical intervention for valve dysfunction. 8. Prophylaxis, some cases require antibiotic prophylaxis, especially in patients with prior history of endocarditis or specific heart conditions. 9. Prognosis, dependent on the causative organism, valve involved, and the timely initiation of treatment. Conclusion, this case exemplifies the complex interplay between the immune response and pathogenesis in bacterial endocarditis. Medical students should understand the underlying mechanisms, clinical manifestations, diagnostic tools, and treatment modalities. Where to find more info? Information on bacterial endocarditis and immune complexes can be found in medical textbooks focusing on immunology, cardiology, and nephrology, as well as guidelines from professional medical organizations.
What is eosinophilic pneumonia? Patients with eosinophilic pneumonia often present with rapidly progressive shortness of breath, which can escalate to acute respiratory failure in severe cases. Additional symptoms include persistent cough, fatigue, night sweats, fever, and unintended weight loss. Hypoxia may be observed in advanced cases. Acute eosinophilic pneumonia, AEP, is defined as a rare disorder involving a rapid accumulation of eosinophils, a type of white blood cell, in the lungs. These cells are generally produced in response to allergens, infections, or inflammation. Diagnosis is usually a combination of clinical presentation, laboratory tests, and imaging. CBC with differential often shows elevated eosinophil counts in the blood are often indicative of the condition. Bronchoalveolar lavage, BAL, often shows eosinophilia in BAL fluid, confirms the diagnosis, and can show eosinophil levels significantly higher than what is typically seen in peripheral blood. Chest X-rays and high-resolution CT scans generally reveal diffuse bilateral infiltrates. While CT scans may not specifically differentiate eosinophilic pneumonia from bacterial pneumonia, they are important for ruling out other conditions. Some cases of eosinophilic pneumonia are linked to infections from bacteria like Streptococcus and parasites like Ascaris lumbricoides or Strongyloides stercoralis. The disease is extremely rare, and specific statistical data are limited. However, most cases are idiopathic, with some triggered by external factors like changes in smoking habits or drug intake. The disease can be idiopathic or triggered by changes in tobacco use or medication. Treatment generally involves corticosteroids, and outcomes are often favorable without relapses. For further information, you can consult resources like the National Organization for Rare Disorders, NORD, and the American Thoracic Society, ATS.
What is the role of deer mice in the spread of hantavirus to humans? Deer mice, Paramyscus maniculatus, are a significant vector for the transmission of hantavirus to humans. Since the recognition of hantavirus pulmonary syndrome, HPS, in the United States in 1993, approximately 728 cases have been documented. The virus spreads primarily through contact with infected deer mice, urine, droppings, or nesting materials, and it has a high mortality rate of around 38%. Epidemiology and transmission. According to the Centers for Disease Control and Prevention, CDC, deer mice are the main reservoir for the Syn-nombre hantavirus, which accounts for about 75% of all HPS cases in the United States. In specific endemic areas, up to 40% of deer mice are carriers of the virus. Humans typically contract the virus via inhalation of aerosolized particles from rodent excreta. Clinical presentation and diagnosis. Symptoms of hantavirus infection often commence with fever, fatigue, and muscle aches, and later advance to severe respiratory distress. Approximately half of HPS cases present with nausea, vomiting, and diarrhea. Diagnosis is usually confirmed through serological testing for hantavirus-specific antibodies. Further reading. For further understanding of the role of deer mice in the transmission of hantavirus, you may refer to academic articles such as Epidemiology of Hantavirus Infections in Humans, a comprehensive, global overview, as well as various CDC publications on this topic. How does trastuzumab, Herceptin, down-regulate HER2, NOI receptors and inhibit intracellular signaling pathways in breast cancer treatment? Introduction. Trastuzumab, Herceptin, a monoclonal antibody, specifically targets HER2 (NOI) receptors and plays a crucial role in the management of HER2-positive breast cancer, constituting approximately 20–25% of breast cancer cases. This case study examines its mechanism of action, statistics, and therapeutic implications. 1. Patient presentation. A 55-year-old female patient was diagnosed with HER2-positive breast cancer, characterized by the overexpression of the HER2 (NOI) receptor. 2. Mechanism of action. 3. Binding to HER2 receptor. Trastuzumab binds to the extracellular domain of the HER2 (NOI) receptor. Downregulation. It inhibits the cleavage of the receptor, leading to a decrease in HER2 signaling, effectively down-regulating HER2 (NOI) receptors. 1. Inhibition of signaling pathways. By binding to HER2, trastuzumab blocks downstream intracellular signaling pathways such as the PI3K, ACT pathway, thus inhibiting tumor cell growth. 2. Treatment and results. Trastuzumab therapy. The patient underwent trastuzumab-based therapy, part of standard treatment for HER2-positive breast cancer, showing a 15–20% improvement in survival rates. 1. Follow-up. Regular monitoring and combination therapy, reducing the risk of recurrence by approximately 50%. 2. Exam-focused facts. 3. Trastuzumab, a monoclonal antibody targeting HER2 (NOI) receptors. 4. HER2-positive breast cancer constitutes 20–25% of breast cancer cases. 5. Mechanism. Downregulation of HER2 (NOI) receptors and inhibition of signaling pathways. 6. Treatment success. Improves survival by 15–20% and cuts recurrence risk by 50%. 7. Side effects. Cardiotoxicity in 2–7% of patients, lung issues in 1–4% of patients. 8. Combination therapy, often used with chemotherapy for enhanced effects. 9. Resistance, occurs in 15–20% of cases, ongoing research to overcome it. Clinical trials, extensive studies and trials have established its efficacy and safety. Historical context, FDA approved in 1998, transformed HER2-positive breast cancer treatment. Conclusion, trastuzumab's ability to down-regulate HER2 (NOI) receptors and inhibit intracellular signaling pathways has revolutionized the treatment of HER2-positive breast cancer. Awareness of its mechanism, statistical impact, and potential side effects is crucial for medical professionals. Where to find more info? Consult oncology textbooks, clinical oncology journals, and guidelines from cancer societies for detailed insights. Smallpox unveiled. A statistical and historical insight into a once-feared disease. How bad was smallpox, and what were the facts? Question. What were the specific symptoms of smallpox, and what was the progression of the disease? Answer. Smallpox began with fever and malaise, followed by a rash that turned into pus-filled blisters. The mortality rate was around 30%, but the variola major strain could result in mortality rates of up to 50%. The variola minor strain had a mortality rate of about 1%. Question. How prevalent was smallpox throughout history? Answer. Smallpox is estimated to have caused between 300 and 500 million deaths in the 20th century alone. It has been a significant scourge throughout human history, affecting populations across the globe. Question. What is the connection between smallpox and the first vaccine? Answer. Edward Jenner developed the first smallpox vaccine in 1796 using cowpox material, coining the term vaccine from the Latin word for cow, vacca. This laid the foundation for modern immunology. Question. How did smallpox contribute to the decline of the Aztec and Inca empires? Answer. Smallpox was introduced to the Americas by European colonizers, leading to large-scale epidemics. It contributed to the fall of the Aztec and Inca empires, with mortality rates exceeding 50% in some native populations. Question. What were the unique methods employed to eradicate smallpox? Answer. Eradication strategies included ring vaccination, where immediate vaccination of contacts and potential contacts of a diagnosed case was carried out. This method was essential in the late stages of the eradication campaign. Question. How did smallpox shape medical ethics and laws? Answer. Compulsory vaccination laws and the resulting public resistance in the 19th and early 20th centuries led to landmark legal cases that shaped modern public health law and medical ethics. Question: how was smallpox used as a biological weapon? Answer: during the French and Indian War, British forces deliberately gave smallpox-contaminated items to Native Americans. This is one of the earliest documented cases of biological warfare. Question: what is the current status of smallpox virus stocks? Answer: as of now, known stocks of the smallpox virus are held in high-security labs in the United States and Russia. The debate over whether to destroy these stocks continues, given the potential research value and risks associated with retention. Further information. For an exhaustive look into smallpox, readers may explore scientific publications, historical documents, and resources from organizations such as the World Health Organization and the Centers for Disease Control and Prevention. Tuberculosis and civilization. A journey through time. How did TB shape history, wars, laws, and cultural beliefs? An insight for medical professionals, nursing students, and others. Question: which historical figures were known to have contracted TB? Answer: notable individuals such as George Orwell, Franz Kafka, Eleanor Roosevelt, and John Keats suffered from TB. The disease played a significant role in the lives and works of many writers, artists, and politicians. Question: what role did TB play in shaping art and literature? Answer: TB influenced the Romantic era, with its association with melancholy and tragic beauty. Characters with consumption, or TB, appear in works like La Bohème, by Puccini, and La Traviata, by Verdi. Question: how did TB affect military campaigns and wars? Answer: TB was a major cause of death in military barracks and during wartime. Its impact on armies has been documented in various conflicts, including World War I and the American Civil War. Question: how did laws and policies evolve in response to TB? Answer: TB led to public health initiatives and laws aimed at controlling the disease, such as mandatory screening, isolation of patients, and regulations governing living conditions in urban areas. Question: what influence did TB have on religious beliefs and practices? Answer: in some cultures, TB was seen as a divine punishment or a test of faith. Religious figures and institutions often played roles in caring for TB patients, and some religious communities emphasized healing and compassion in response to the disease. Question: how did TB shape statistical methods and epidemiology? Answer: the study of TB led to advancements in statistical methods and the field of epidemiology. Pioneers like Robert Koch contributed to our understanding of infectious disease transmission and control. Question: what are some unusual or lesser-known facts about TB? Answer: some uncommon facts include the use of TB tourism for treatment in sanatoria, the cultural symbolism of consumptive chic in the 19th century, and the role of milk pasteurization in controlling bovine TB. Question: how has TB influenced global health initiatives and international cooperation? Answer: TB control has been a focus of international efforts, leading to collaboration between countries, non-governmental organizations, and global health bodies like the World Health Organization. Question: how is TB connected to the history of vaccines and treatments? Answer: TB led to research and development of various treatments, including the BCG vaccine. The quest for effective TB drugs shaped medical research and pharmaceutical development. Further information. For an in-depth look at the historical, legal, cultural, and scientific impact of TB, readers can refer to scholarly articles, historical texts, medical journals, and cultural studies from reputable sources. How do different types of anemia based on MCH and MCHC? The values of mean corpuscular hemoglobin, MCH, and mean corpuscular hemoglobin concentration, MCHC, offer critical diagnostic insights into the type and severity of anemia. This presentation will dissect how MCH and MCHC vary according to specific anemias. Iron deficiency anemia scenario, low MCH and low MCHC explanation. Limited iron inhibits hemoglobin production, lowering MCH and MCHC. B12 deficiency scenario, high MCH and high MCHC explanation. Reduced cell division due to B12 deficiency generates larger, hemoglobin-rich cells, elevating MCH and MCHC. Thalassemia scenario, normal MCH but low MCHC explanation. Altered hemoglobin synthesis affects the RBC size but not its hemoglobin concentration, altering MCHC more than MCH. Anemia of chronic disease scenario. Normal MCH and MCHC explanation. Inflammatory markers interfere with iron metabolism, without significantly altering MCH or MCHC. Anemia of liver disease scenario. Elevated MCH but normal MCHC explanation. Altered liver metabolism causes higher hemoglobin content per RBC, affecting MCH. Anemia of renal disease scenario. Normal to low MCH and MCHC explanation. Reduced erythropoiesis due to low erythropoietin affects overall hemoglobin without altering MCH and MCHC. Hemolytic anemia scenario. Elevated MCH and MCHC explanation. Reduced RBC count elevates MCH and MCHC as the remaining cells may have higher hemoglobin content. Acute blood loss anemia scenario. Normal MCH and MCHC initially, declining with persistent loss explanation. Initially stable metrics may decline with ongoing blood loss, affecting both MCH and MCHC. Where to find more information, consult the American Society of Hematology, Clinical Laboratory Standards Institute, or hematology textbooks for further insights. How is S. bovis endocarditis linked to gastrointestinal lesions and what are common causes of endocarditis? An insight for medical students, nursing students, and other healthcare students. Question: what is S. bovis endocarditis, and how is it typically diagnosed? Answer: S. bovis endocarditis is an infection of the heart's inner lining caused by the Streptococcus bovis bacteria. Diagnosis usually involves blood cultures, echocardiography, and assessment of clinical symptoms. Question: why is there a strong association between S. bovis endocarditis and gastrointestinal lesions? Answer: S. bovis endocarditis is associated with gastrointestinal lesions as the bacteria inhabit the gastrointestinal tract. Any gastrointestinal lesion can allow entry of the bacteria into the bloodstream, leading to endocarditis. Question: what types of gastrointestinal lesions are most commonly associated with S. bovis endocarditis? Answer: gastrointestinal lesions related to S. bovis endocarditis include colon polyps, colorectal cancer, diverticulitis, and inflammatory bowel disease. Question: what are the most common causes of endocarditis in general? Answer: the most common causes of endocarditis include infections with bacteria like Streptococcus, Staphylococcus, and Enterococcus species. Underlying heart conditions, use of intravenous drugs, and certain medical procedures can increase the risk. Question: how does endocarditis usually develop? Answer: endocarditis develops when bacteria or other microorganisms enter the bloodstream and attach to damaged areas of the heart, forming infected clots or vegetations. This can occur through dental procedures, surgery, catheters, or other infections. Question: how should patients with S. bovis endocarditis be evaluated for gastrointestinal lesions? Answer: a thorough gastrointestinal evaluation, including colonoscopy, endoscopy, and imaging studies, is essential for patients with S. bovis endocarditis to detect underlying gastrointestinal lesions or malignancies. Question: how is S. bovis endocarditis treated, and how does the presence of gastrointestinal lesions affect treatment? Answer: treatment involves prolonged antibiotic therapy, possible surgical intervention, and addressing gastrointestinal lesions. Treatment may be tailored based on specific gastrointestinal pathology. Question: what are the long-term outcomes for patients with S. bovis endocarditis and associated gastrointestinal lesions? Answer: outcomes depend on early diagnosis and treatment of both conditions. Comprehensive care can improve prognosis and reduce complications. Further information: the connection between S. bovis endocarditis and gastrointestinal lesions exemplifies the importance of an interdisciplinary approach to patient care. For more in-depth understanding, consult specialized medical textbooks, research publications, or expert medical sources online. How long is shingles contagious? Shingles is contagious from the time the rash appears until all the blisters have crusted over, which is generally within 5 to 7 days. Historical facts: zoster, commonly known as shingles, is a reactivation of the varicella zoster virus, VZV, the same virus that causes chickenpox. The term shingles comes from the Latin word cingulus, which means belt or girdle, reflecting the belt-like pattern the rash often forms. Isolation practices date back to when varicella and zoster were considered highly contagious. Case presentation. A patient presents to the ER with a painful, blistering rash distributed along a dermatome. A diagnosis of zoster is made, raising the question of isolation. Isolation considerations. Zoster is less contagious than chickenpox but can still spread VZV. Airborne and contact precautions are recommended for disseminated zoster. Localized zoster requires only standard precautions unless it cannot be covered. Course and resolution. Typically, a case of shingles resolves within 3 to 5 weeks. Some patients may experience postherpetic neuralgia, a complication that can prolong pain. Statistics. About 1 million cases of zoster occur annually in the U.S. Hospitalized patients with weakened immune systems are at greater risk of contracting VZV. Where to find more information? Consult the Centers for Disease Control and Prevention, CDC, and Infectious Diseases Society of America, IDSA, guidelines for detailed isolation and management recommendations. What historical texts mention herpes simplex virus, HSV, and how was painful urination associated with it described? Herpes simplex virus, HSV, and its symptoms, including painful urination, have been recognized for centuries, although the understanding and terminology have evolved. Descriptions of symptoms resembling those caused by HSV can be found in various historical medical texts. Historical books that mentioned conditions related to HSV and painful urination. 1. De Medicina by Aulus Cornelius Celsus, an early Roman text that discusses skin eruptions, possibly referring to herpes. 2. Epidemics by Hippocrates, contains descriptions of sores and conditions that might be related to herpes, though the terminology differs. 3. Canon of Medicine by Avicenna. This medieval text includes references to conditions that may be akin to HSV, including painful urination. 4. Surgical Anatomy by Jacques-Fabien Gautier d'Agaty, an 18th-century work describing various ailments, possibly including herpes-related symptoms. Facts about HSV and painful urination in historical context. 1. Descriptions of herpes-like conditions can be traced back to ancient Greek and Roman medical writings. 2. The terminology and understanding of HSV have evolved over time. Early descriptions might not directly correspond to the modern diagnosis. 3. Painful urination associated with HSV may have been described differently in historical texts, without a clear link to the virus itself. 4. Treatments for herpes-like conditions in historical times were varied and often based on limited medical knowledge. 5. The stigma associated with sexually transmitted infections, STIs, may have influenced how these conditions were recorded and treated. 6. Modern understanding of HSV, including its link to painful urination, has been developed through scientific advancements and research. 7. The study of historical texts helps shed light on early perceptions and management of HSV and related symptoms. 8. Continuous research and adherence to contemporary medical guidelines are vital for proper diagnosis and treatment of HSV today. Where to find more info? Further insights into the history of HSV can be found in scholarly texts on ancient and medieval medicine, medical history journals, and resources from academic institutions specializing in the history of medicine. Hyperkalemia, PSEUDOHYPERKALEMIA, and EKG changes. After diagnosing hyperkalemia, immediate follow-up with an EKG and a second blood sample is crucial to rule out pseudohyperkalemia. Review medications and confirm that intravenous fluids don't contain potassium. Pseudohyperkalemia can occur due to hemolysis, extreme leukocytosis, and even thrombocytosis. Case scenario: the patient with bradycardia and altered mental status. A 65-year-old patient with renal failure and potassium-sparing diuretic use presents with bradycardia and altered mental status. EKG shows peaked T waves and widened QRS complexes. Initial potassium levels are high, necessitating urgent intervention. Identifying EKG changes. Peaked T waves, sharp, narrow, and tall. First EKG sign. 2. Widened QRS complexes. Signifies severe hyperkalemia, increased arrhythmia risk. Prolonged PR interval, less common but precedes QRS widening. Clinical pearls. Medications causing hyperkalemia. angiotensin-converting enzyme, ACE, inhibitors, angiotensin II receptor blockers, ARBs, potassium-sparing diuretics, and certain beta blockers can contribute. Absence of EKG changes doesn't rule out hyperkalemia. EKG is sensitive, not specific. Absence of EKG changes is not definitive. Pseudohyperkalemia. Consider if the clinical picture is inconsistent with potassium levels. Thrombocytosis can also lead to pseudohyperkalemia by releasing potassium during platelet activation. Repeat tests. Review medications meticulously and ensure no potassium in IV fluids. Diagnostic measures. Repeat serum potassium. Continuous EKG monitoring. Statistics. Hyperkalemia has a prevalence of 1–10% in hospitalized patients. Thrombocytosis-related pseudohyperkalemia is relatively rare but clinically significant. Further reading. For more details, consult Hyperkalemia and Hypokalemia in Harrison's Principles of Internal Medicine. How to identify ECG changes in hypokalemia, potassium's role in EKG, and diuretic-induced hypokalemia. Hypokalemia can significantly affect ECG findings. Identifying these changes includes looking for ST depression, decreased or inverted T waves, increased amplitude of U waves, and prolongation of both the QT and PR intervals. Potassium is essential for cellular depolarization and repolarization, which the EKG measures. Diuretics exacerbate hypokalemia by promoting potassium loss in urine. Case scenario: the patient with weakness, fatigue, and ECG abnormalities. A 60-year-old patient with a history of diuretic use for hypertension presents with generalized weakness and fatigue. The ECG reveals ST depression and prominent U waves. Lab tests confirm hypokalemia. How to identify EKG changes. ST depression appears as a downward deflection between the QRS complex and T wave. T wave changes. Initially, decreased amplitude. As hypokalemia worsens, T waves may invert. Prominent U waves, visible after the T wave, may be mistaken for T waves, leading to a perceived prolonged QT interval. QT prolongation, best observed in leads 2, V5, and V6, should be corrected for heart rate, QTC. PR interval prolongation, widen space between the onset of the P wave and start of the QRS complex. Clinical pearls. Diuretics, particularly thiazides and loop diuretics, increase renal excretion of potassium, leading to hypokalemia and the associated ECG changes. Potassium is crucial for cellular membrane stability. Its deficiency alters depolarization and repolarization, leading to the observed ECG changes. Diagnostic measures. Serum potassium levels are essential for diagnosis. Continuous ECG monitoring is advisable given the arrhythmogenic potential. Management. Prompt potassium replacement is crucial to prevent malignant arrhythmias. Statistics. Hypokalemia is found in about 20% of hospitalized patients and is associated with a significant increase in mortality when severe. Source: Archives of Internal Medicine. Further reading. For a comprehensive understanding, consult ECG in Emergency Medicine and Acute Care, or the Archives of Internal Medicine. Iron deficiency anemia and its direct link to pica behavior. Why do I crave ice? Patient presentation. 1. Patient, 35-year-old female. 2. Chief complaint: fatigue, weakness, and an unusual craving for ice. 3. Medical history, reports heavy menstrual periods. 4. Exam findings: pale conjunctiva, brittle nails, spoon-shaped nail beds, koilonychia. 5. Lab results: hemoglobin, 9 grams dl, low. Hematocrit, 27%, low. Ferritin, 12 nanograms per milliliter, low. MCV, 70 fluid, low. Iron deficiency is one of the most common nutritional deficiencies in the world. According to the World Health Organization, WHO, it is a significant public health issue affecting both developing and developed countries. Estimates suggest that nearly 25% of the world's population is anemic, much of which is due to iron deficiency. In the United States, iron deficiency is most prevalent among young children and women of childbearing age, particularly those who are pregnant or have heavy menstrual periods. According to the Centers for Disease Control and Prevention, CDC, About 9% of toddlers aged 1–2 years and 7–9% of women aged 12–49 years are iron deficient. Iron deficiency can have significant health impacts, including impaired cognitive function in children, increased susceptibility to infection, and increased maternal and child mortality rates. 1. Facts about pica and iron deficiency anemia. Direct connection. Pica, specifically pagophagia, is directly related to iron deficiency, and resolving the deficiency can also resolve the pica. Menstrual blood loss. Heavy menstrual periods are a common cause of iron deficiency anemia in women of reproductive age. Correction of pica. Iron supplementation to treat the iron deficiency anemia often leads to a disappearance of pica symptoms. Impact on daily life. Both conditions can have a profound impact on the quality of daily life, affecting energy levels and overall health. Dental complications. The act of chewing ice can lead to dental problems like enamel erosion. Lab diagnostics. Iron deficiency is often evidenced by low levels of hemoglobin, hematocrit, and ferritin in lab tests. Treatment plan. Oral iron supplementation is the typical first step in treating iron deficiency anemia. Psychoeducation. Patients may not be aware that their cravings for non-food items are related to a medical issue and may benefit from education. Importance of diet. A balanced diet rich in iron can assist in preventing iron deficiency anemia. Full recovery. Iron deficiency anemia can take several months to correct, depending on the severity. Consult a specialist. For severe cases, consultation with a hematologist may be necessary. High prevalence. Iron deficiency anemia is one of the most common nutritional deficiencies worldwide, making its symptoms highly relevant for medical professionals to recognize. Summary. This case underscores the direct link between iron deficiency anemia and pica, particularly the craving for ice, pagophagia. Both medical and nursing students should be adept at diagnosing and managing these interconnected conditions to offer holistic patient care. For more information, for additional details on pica and iron deficiency anemia, please consult reputable medical sources such as PubMed, medical textbooks, and the World Health Organization guidelines. What is the MCHC in a CBC and how is it used in anemia diagnosis? Introduction. The mean corpuscular hemoglobin concentration, MCHC, is a measure included in a complete blood count, CBC. It calculates the average concentration of hemoglobin in red blood cells. MCHC calculation. The MCHC is calculated by dividing the total hemoglobin by the hematocrit and multiplying by 100. Normal, low, and high MCHC. 1. Normal MCHC indicates no specific anemia and is generally 32–36 grams per deciliter. 2. Low MCHC points towards microcytic hypochromic anemias like iron deficiency anemia. 3. High MCHC, extremely rare but can be due to spherocytosis or intrinsic red cell defects. Clinical scenario for MCHC use. Consider a patient presenting with fatigue and dyspnea. A CBC reveals anemia with a low MCV and low MCHC, suggesting iron deficiency anemia. Another patient with similar symptoms with anemia characterized by a normal MCHC and low MCV may likely have thalassemia. Key differentiator in diagnosis. 1. Anemia with low MCV and low MCHC points towards iron deficiency anemia. 2. Anemia with low MCV and normal MCHC raises suspicion for thalassemia. Diagnostic steps. 1. Beta thalassemia, diagnosed with hemoglobin electrophoresis. 2. Alpha thalassemia, identified using a specific genetic test for alpha-globin genes. Clinical pearls. Understanding the MCHC is crucial for differential diagnosis of anemias, and it guides the clinician in the next steps for diagnostic tests and treatment. For an in-depth understanding of MCHC, consult specialized hematology textbooks, peer-reviewed journal articles, or guidelines from professional medical organizations like the American Society of Hematology. How can we differentiate monkeypox from smallpox? The role of lymphadenopathy and laboratory evaluation in current epidemics. Historical facts. Monkeypox was first discovered in 1958 in laboratory monkeys. Smallpox has ancient roots but was declared eradicated in 1980 after a successful worldwide vaccination campaign. Both are caused by viruses of the orthopoxvirus genus. Lesser-known facts about monkeypox. 1. Monkeypox can be transmitted via respiratory droplets, although it is primarily zoonotic. 2. There are two main clades of monkeypox, the West African and the Congo Basin, with the latter being more severe. 3. Unlike smallpox, monkeypox has a hemorrhagic phase that can occur in severe cases. Is there a monkeypox vaccine? Currently, there is no specific vaccine for monkeypox. However, the smallpox vaccine has shown to be about 85% effective in preventing monkeypox as well. Recent outbreaks of monkeypox have been reported in Central and Western Africa, as well as isolated cases in other parts of the world. The virus seems to be resurging in some regions, leading to renewed research and surveillance efforts. Monkeypox in monkeys versus humans. While initially identified in monkeys, the disease is primarily zoonotic, affecting a range of animals including rodents. Human infections appear to be more severe, characterized by fever, rash, and significant lymphadenopathy. Case presentation. Differentiating monkeypox from smallpox. In a patient with generalized rash, a patient arrives with fever, malaise, and a generalized vesicular rash. Clinical examination reveals marked lymphadenopathy. Laboratory evaluation is necessary to differentiate the condition from smallpox, as clinical symptoms are largely indistinguishable. PCR confirms monkeypox. Statistics. 1. Monkeypox affects thousands annually in Central and Western Africa. 2. Smallpox, eradicated, but had a historic 30% mortality rate. Diagnostic considerations. 1. Clinical manifestations are similar, emphasizing the need for lab tests. 2. Lymphadenopathy is more prominent in monkeypox. 3. PCR and viral cultures remain the diagnostic gold standard. Where to find more information? To delve deeper into the subject, consult resources from the Centers for Disease Control and Prevention, CDC, or the World Health Organization, WHO. Dealing with mono at 30. A deep dive into Epstein-Barr virus, EBV, symptoms, diagnosis, and treatment. Introduction. Epstein-Barr virus, EBV, is known for causing infectious mononucleosis, or mono. This case study explores the manifestation of EBV in a 30-year-old patient, focusing on symptoms, diagnosis, definitive tests, false positives, optimal testing methods, and epidemiology. Patient presentation. A 30-year-old individual sought medical care for persistent fatigue, sore throat, fever, and swollen lymph nodes. Evaluation and findings. 1. Physical examination found enlarged tonsils with exudate. 2. Initial monospot test was performed, subject to false positives. 3. Confirmatory EBV serology tests were positive, providing definitive evidence of infection. 4. Liver function tests were mildly elevated. Treatment. 1. Supportive care, including hydration, rest, and over-the-counter pain relief, was prescribed. Additional exam-focused facts. 1. Approximately 50% of the population in the U.S. has serologic evidence of exposure to the Epstein-Barr virus by 5Y01. Serologic evidence of exposure refers to the presence of specific antibodies against EBV components, such as viral capsid antigen, VCA, IG, indicating either past or current infection. 2. EBV is a herpesvirus, leading to lifelong latent infection. 3. Transmission commonly occurs via saliva. 4. The monospot test is rapid but may produce false negatives or positives. 5. Definitive diagnosis of EBV requires serologic testing for VCA, IgM and IG, with IgM indicating acute infection and IG suggesting past exposure. 6. Chronic EBV is associated with malignancies and autoimmune diseases. 7. Treatment is primarily supportive, as no specific antiviral therapy for EBV exists. 8. Complications can include splenic rupture, hepatitis, and neurological disorders. Conclusion. This case illustrates the ubiquity and varied presentation of EBV. Recognizing both typical and atypical manifestations and understanding the diagnostic methods, including the importance of serologic evidence, is vital for accurate diagnosis and management. Where to find more info? Detailed information on EBV can be found in medical textbooks, academic journals, CDC guidelines, and online resources like UpToDate. What are the most common causes of PYELONEPHRITIS? Fact: E. coli and Klebsiella species are responsible for more than 90% of pyelonephritis cases. Case study: identifying the most common causes of pyelonephritis in a patient. Background: a patient in their 40s presents with symptoms suggesting pyelonephritis. What are the most common causes of pyelonephritis in such cases? Physical examination: patient shows signs of pyelonephritis including fever, tachycardia and costovertebral angle tenderness. Urinalysis and urine culture. Test results show the most common cause of pyelonephritis, positive for gram-negative bacteria, E. coli. Epidemiology and pathophysiology. Pyelonephritis statistics affects approximately 15-17 per 10,000 females and 3-4 per 10,000 males annually. Most common causes are E. coli and Klebsiella species. E. coli is responsible for approximately 75-90% of pyelonephritis cases, while Klebsiella species accounts for up to 6-17%. Together, they are implicated in more than 90% of pyelonephritis cases. E. coli and Klebsiella species are common bacteria that reside in the gastrointestinal tract. Their proximity to the urethra, combined with certain virulence factors, make them the most frequent causes of urinary tract infections, including pyelonephritis. Virulence factors and the virulence factors and pathophysiology behind the predominance of E. coli and Klebsiella species in pyelonephritis include features such as fimbriae, capsules, and biofilm formation. Fimbriae are hair-like appendages that enable the bacteria to adhere to uroepithelial cells. Capsules help the bacteria resist phagocytosis and evade the host's immune response. Additionally, the ability to form biofilms allows these bacteria to adhere to surfaces within the urinary tract, making them more resistant to antibiotic treatment. Resist antibiotics. Enterococcus, Pseudomonas aeruginosa, and Proteus mirabilis are among the other causes of pyelonephritis. Treatment for pyelonephritis should target the most common causes to prevent complications like renal scarring. Conclusion: in addressing the question, what are the most common causes of pyelonephritis? E. coli and Klebsiella species are the most common causes. Accurate diagnosis is critical for effective treatment. Further reading. To learn more about the most common causes of pyelonephritis, consider reading Epidemiology and Pathogenesis of Pyelonephritis in the Journal of Infectious Diseases. What causes primary amoebic meningoencephalitis and how is it contracted? Naegleria fowleri is a free-living amoeba responsible for causing primary amoebic meningoencephalitis, PAM. This infection is typically contracted 2-5 days after swimming in warm, freshwater lakes and ponds contaminated with the amoeba. The amoeba usually enters the body through the nose and then makes its way to the brain, causing severe inflammation. Warm freshwater. The infection is mainly associated with swimming in warm freshwater lakes and ponds. PAM is extremely rare but often fatal, with fewer than 10 cases reported per year in the U.S. Fatality rate: nearly 97% of cases are fatal, even with treatment. The amoeba is naturally found in warm, freshwater environments and has a propensity to penetrate the nasal mucosa, making its way to the central nervous system where it causes severe inflammation and damage. PAM is typically contracted by swimming in contaminated freshwaters like lakes and ponds. Once the amoeba enters through the nasal passage, it migrates along olfactory nerves to the brain, resulting in rapid onset and often fatal meningoencephalitis. For further insights, consider articles such as Primary Amoebic Meningoencephalitis, A Comprehensive Review, and Naegleria fowleri, Ecology, Infection, and Prevention. Why do 40% of MS patients develop optic neuritis? Optic neuritis is a frequent symptom in patients with multiple sclerosis, MS, with approximately 40% of MS patients experiencing this at some point in the course of their disease. It manifests as variable vision loss, pain during eye movement, and scotoma affecting macular vision. Definition of scotoma: a scotoma is a specific area of vision loss or impairment, generally described as a blind spot, which often impacts central vision. It's a key symptom in optic neuritis and is typically evaluated through visual field testing. Common case presentation: a patient presents with sudden, unilateral vision loss over the course of hours to days. The patient also complains of eye pain that worsens with movement. On examination, visual acuity is reduced, and color vision is impaired. A scotoma or blind spot is identified during visual field testing. Optic neuritis often serves as an initial indicator of MS, but can also occur at any stage of the disease. The inflammation of the optic nerve is thought to be due to a misguided immune response, similar to the autoimmune mechanism in MS itself. Symptoms of optic neuritis: variable vision loss, pain on eye movement, scotoma affecting macular vision. Diagnostic considerations. 1. Visual evoked potential test. This test measures the electrical activity in the visual pathway when the eye responds to a visual stimulus like a flashing light or checkerboard pattern. It is useful for identifying lesions or abnormalities along the optic nerve pathway. 2. Optical coherence tomography helps evaluate the thickness of the retinal nerve fiber layer. 3. MRI to visualize the optic nerve and rule out other potential causes. 4. Fundoscopic examination to evaluate the optic disc for signs of swelling or inflammation. Statistics and prevalence. In the general population, optic neuritis occurs with a prevalence rate of approximately 5 per 100,000 people. Among MS patients, however, the occurrence spikes to 40%, highlighting its significance in MS management and prognosis. Why is it important? The onset of optic neuritis in an MS patient is often considered an important event, potentially signaling a change in the disease course and requiring adjustments in treatment strategy. Further reading. For those interested in in-depth study, consider reading the journal article, Optic Neuritis as an Early Sign of Multiple Sclerosis, which details the pathophysiology, diagnosis, and management of optic neuritis in MS patients. What causes pelvic inflammatory disease, PID, and how is it diagnosed and treated? The most sensitive test for PID is the detection of increased WBC in vaginal fluid, with a sensitivity of 78% and a specificity of 39%. PID is commonly caused by sexually transmitted infections such as chlamydia trachomatis and Neisseria gonorrhoeae, and often spreads through sexual contact or iatrogenic means like childbirth or abortion. Symptoms may include pain in the lower abdomen, fever, unusual discharge, and painful urination or intercourse. The high sensitivity of this test enables effective ruling out of PID, while its low specificity may lead to false positives, requiring further diagnostic methods such as endometrial biopsy, ultrasound, or laparoscopy. Early and accurate diagnosis is crucial for successful treatment, preventing complications like infertility and chronic pelvic pain. Emphasizing preventative measures, such as regular screening for STIs and patient education on safe sexual practices, is an integral part of managing PID. Facts about PID. PID is an infection of the female reproductive organs, including the uterus, fallopian tubes, and ovaries. Common causes include sexually transmitted infections, especially chlamydia trachomatis and Neisseria gonorrhoeae. It can lead to serious complications such as infertility, ectopic pregnancy, and chronic pelvic pain. Early symptoms may include pain in the lower abdomen, fever, unusual discharge, and painful urination or intercourse. Diagnosis may involve a combination of clinical evaluation, laboratory testing, like the WBC test, and imaging. Treatment typically involves antibiotics, often in combination, to address possible mixed infections. Hospitalization may be required in more severe cases or when oral antibiotics are not sufficient. Preventive measures include safe sex practices, regular STI screening, and prompt treatment of STIs. Long-term follow-up may be necessary to monitor and manage potential complications. For further information, medical professionals and students can refer to authoritative sources like the CDC, ACOG, and WHO, as well as medical textbooks and peer-reviewed articles on PubMed. What was pelvic inflammatory disease, PID, like in the Middle Ages, and what historical books mentioned conditions related to it? Pelvic inflammatory disease, PID, may have been described in various ways in medieval medical texts, although specific terminology has evolved. Historical figures like Eleanor of Aquitaine and Anne of Bohemia may have suffered from conditions resembling PID. Historical books that mentioned conditions related to PID, chlamydia, gonorrhea. 1. Trotula. A collection of texts by female practitioners in Salerno, providing insight into women's health issues, including conditions resembling PID. 2. De Morbo Gallico, on the French disease, a treatise discussing syphilis, which may also allude to gonorrhea. 3. Canon of Medicine by Avicenna includes descriptions of urogenital symptoms that may relate to these diseases. 4. Gynecology by Cyrenus of Ephesus, an ancient text with information about female reproductive health, possibly including conditions similar to PID. Facts about PID in the Middle Ages. 1. PID might have affected prominent figures like Eleanor of Aquitaine and Anne of Bohemia. 2. The exact prevalence of PID in the Middle Ages is unknown, but gynecological conditions resembling PID were likely common. 3. Treatments often involved herbal remedies, bloodletting, and prayer. 4. Many treatments were likely ineffective and could exacerbate the condition. 5. The connection between sexually transmitted infections, STIs, and PID was not understood. 6. Midwives and local healers played a crucial role in treating PID. 7. The social stigma associated with gynecological diseases may have led to underreporting. 8. Texts like the Trotula provide insight into how women's health issues were treated during this period. 9. The study of PID in the Middle Ages offers insights into broader societal attitudes towards women's health and sexuality. 10. Ongoing exploration of historical treatments and cases helps understand the evolution of medical practice and women's healthcare history. Where to find more info? Additional historical information can be found in scholarly texts on medieval medicine, medical history journals, and specialized history of medicine institutions. What is poikilocytosis and how is it managed? Poikilocytosis refers to the presence of abnormally shaped red blood cells, RBCs, in a peripheral blood smear. Poikilocytosis is often an indicator of underlying issues that may present symptoms like anemia, fatigue, or shortness of breath. Symptoms of poikilocytosis. Poikilocytosis itself doesn't present symptoms. It serves as an indicator of underlying issues that may cause symptoms like anemia or fatigue. Case scenario: patient with anemia and poikilocytosis in peripheral blood smear. A 35-year-old patient comes in with fatigue and pallor. CBC shows anemia, and a peripheral blood smear reveals poikilocytosis with various irregularly shaped RBCs. Clinical pearls for managing poikilocytosis. 1. Identification of poikilocytosis, best identified through a peripheral blood smear. 2. Diagnostic steps in poikilocytosis. Further tests such as iron studies, reticulocyte count, B12, folic acid levels, and spleen ultrasound may be needed. 3. RDW and MCHC in poikilocytosis. RDW may be elevated. MCHC usually remains normal unless there is hemolysis. 4. Haptoglobin in poikilocytosis, only decreased in intravascular hemolysis. 5. Causes of poikilocytosis, frequently seen in conditions like iron deficiency anemia, hemolytic anemia, liver disease, and B12 and folic acid deficiency. 6. Poikilocytosis without anemia. Further diagnostic testing and possibly a hematologist referral are advisable even if poikilocytosis is present but there's no anemia. Diagnostic measures for poikilocytosis. 1. Complete blood count, CBC. 2. Peripheral blood smear to confirm poikilocytosis. 3. Reticulocyte count. 4. B12 and folic acid levels. 5. Haptoglobin. 6. Spleen ultrasound for poikilocytosis, if suspected splenic involvement. Statistics on poikilocytosis. 1. Poikilocytosis occurs in approximately 10–15% of severe anemia cases. Further reading on poikilocytosis. For more on poikilocytosis, refer to Poikilocytosis, Diagnostic Approach and Clinical Implications, in the American Journal of Hematology. Why does porphyria cause skin blisters? Statistical and clinical insights. Porphyria, a rare condition affecting approximately 1 in 25,000 people in the United States, causes a range of symptoms including skin blistering, due to the accumulation of porphyrins in the body. Studies have shown that these porphyrins, when exposed to light or oxygen, generate unstable and charged molecules like reactive oxygen species, ROS. These reactive molecules can damage skin cells, leading to symptoms like skin blistering, itching, and even skin erosions. About 60% of patients with cutaneous porphyrias experience these skin-related complications. The most common forms of porphyria include Porphyria cutanea tarda, acute intermittent porphyria, and erythropoietic protoporphyria. While Porphyria cutanea tarda can be either sporadic or hereditary, acute types like acute intermittent porphyria mainly cause neurological symptoms, and cutaneous types like Porphyria cutanea tarda and erythropoietic protoporphyria mainly cause skin photosensitivity. Effective diagnosis and management strategies are essential for mitigating these symptoms. For example, patients with Porphyria cutanea tarda can benefit significantly from avoiding light exposure and using other preventative measures. How does the prothrombin 20210A gene mutation affect plasma prothrombin levels? Introduction. The prothrombin 20210A gene mutation is associated with elevated plasma prothrombin levels, contributing to an increased risk of thrombotic events. This mutation is found in about 2–3% of Caucasians and less than 1% of other populations. This case study examines a 45-year-old patient with recurrent venous thromboembolism, VTE. Patient presentation. A 45-year-old male with a history of recurrent VTE is genetically tested and confirmed to have the prothrombin 20210A gene mutation. Mechanism and findings. 1. Prothrombin levels. This mutation results in elevated plasma prothrombin levels. 2. Thrombotic risk. The elevated prothrombin levels nearly double the risk of VTE. Diagnosis and treatment. Genetic testing confirmed the presence of the prothrombin 20210A gene mutation. Anticoagulation. Treatment options include warfarin or direct oral anticoagulants like Xarelto or Eliquis. The necessity for long-term treatment is determined on a case-by-case basis. Exam-focused facts. The mutation leads to elevated prothrombin levels. Prevalence of the mutation is 2–3% among Caucasians and less than 1% in other populations. Elevated prothrombin levels nearly double the risk of VTE. Genetic testing is used for risk stratification. Treatment options often include warfarin or direct oral anticoagulants, DOACs, like Xarelto or Eliquis. Long-term anticoagulation is not always required and is based on clinical context. Differential diagnosis should include causes of thrombophilia such as factor V Leiden and antiphospholipid syndrome. Increased risk of thrombosis and miscarriage during pregnancy for mutation carriers. Lifelong increased risk of thrombotic events exists, but long-term anticoagulation is not always necessary. Conclusion. Understanding the implications of elevated plasma prothrombin levels due to the prothrombin 20210A gene mutation is essential for accurate diagnosis and tailored treatment planning. What are the 3 most common risk factors for renal vein thrombosis? Renal vein thrombosis, RVT, is a condition characterized by clot formation in the renal veins, leading to potential kidney damage if not promptly addressed. 1. The first risk factor for renal vein thrombosis is nephrotic syndrome. This kidney disorder results in the loss of large amounts of protein in the urine and low levels of protein in the blood. The loss of proteins like antithrombin, which normally prevent clotting, predisposes individuals to thrombotic events, including RVT. Symptoms of nephrotic syndrome include leg and feet swelling, high cholesterol levels, and increased susceptibility to infections. 2. The second risk factor for RVT is tumors invading the renal veins. Tumors in proximity to or within the kidneys can obstruct or compress the renal veins, leading to blood flow restriction and a higher propensity for clot formation. Common tumor types include renal cell carcinoma and Wilms tumor in children. 3. The third most common risk factor for renal vein thrombosis is hypercoagulable state. This refers to conditions that make blood more prone to clotting, due to genetic mutations, certain medications, or medical conditions like antiphospholipid syndrome. Statistics and prevalence. As many as 40% of patients with nephrotic syndrome may develop RVT. Early diagnosis and treatment are key to reducing complications. Further reading for a more comprehensive understanding of renal vein thrombosis. Scholarly reviews and academic articles offer in-depth information on its risk factors, diagnosis, and treatment options. Smallpox, a comparative study with chickenpox, measles, and influenza. Transmissibility, peak rates, and the last known case for medical students, nursing students, and healthcare professionals. Question: what were the smallpox infection rates at its peak, and how does this compare to chickenpox, measles, and influenza? Answer. At its peak, smallpox caused an estimated 300 to 500 million deaths in the 20th century alone. It was more localized compared to measles, which has caused large-scale outbreaks. Chickenpox has had widespread prevalence but lower mortality rates, while influenza's impact varies by strain, with pandemics like the 1918 Spanish flu causing significant fatalities. Question. When and where was the last known diagnosis of smallpox, and what were the circumstances surrounding it? Answer. The last known natural case of smallpox was diagnosed in Somalia in 1977. An eradication campaign by the World Health Organization culminated in this last case. However, a laboratory accident in the UK in 1978 led to one additional death. This illustrates the importance of biosafety in handling smallpox and other virulent pathogens. Question. How did smallpox's transmissibility compare to other diseases like chickenpox, measles, and influenza? Answer. Smallpox's R0 value ranged from 3.5 to 6, indicating less transmissibility than measles, 12 to 18, chickenpox, 8 to 12, and certain strains of influenza. Close contact was usually required for smallpox transmission, while the other diseases could spread more easily. Question. How have vaccination efforts contributed to the control and eradication of smallpox? Answer. Smallpox is the only human disease that has been eradicated through vaccination. The concerted effort by the WHO and global partners led to eradication, with the last case in 1977. This contrasts with ongoing vaccination efforts required to control measles, chickenpox, and influenza. Question. What are the clinical symptoms of smallpox, and how do they compare to chickenpox, measles, and influenza? Answer. Smallpox presents with fever, malaise, and a distinctive rash that progresses to pus-filled blisters. Chickenpox and measles also present with rashes but have different patterns and associated symptoms. Influenza primarily affects the respiratory system, contrasting with the skin manifestations of the other diseases. Question. How do public health measures for smallpox compare to those for chickenpox, measles, and influenza? Answer. Smallpox required isolation, contact tracing, and targeted vaccination. Measles and chickenpox control rely on routine vaccination, while influenza involves yearly vaccination and antivirals. These measures are tailored to each disease's specific characteristics. Further information. Smallpox, once a devastating global disease, has been eradicated through successful public health measures. The study of its history and comparison with other infectious diseases offers valuable lessons in epidemiology and disease control. For more in-depth information, consult medical textbooks and relevant epidemiological studies. Smallpox in society. How a disease-shaped history, law, and religion did smallpox influence major historical figures and cultural beliefs? An insight for medical professionals, nursing students, and others. Question. Which historical figures were known to have contracted smallpox? Answer. Several notable individuals were affected by smallpox, including Peter the Great, Elizabeth I of England, and George Washington. Some, like Tsar Peter I, survived, while others, such as Peter II of Russia, succumbed to the disease. Question. How did smallpox affect the succession of leadership in various countries? Answer. Smallpox played a role in shaping dynastic successions and political landscapes. For example, the death of Queen Mary II of England from smallpox led to the ascension of Queen Anne. Similarly, the death of Peter II of Russia led to a crisis of succession in the Russian Empire. Question. What role did smallpox play in the colonization of the New World? Answer. Smallpox was a significant factor in the conquest of native populations in the Americas. The disease decimated indigenous communities, contributing to the collapse of civilizations like the Aztecs and Incas. Question. How did smallpox influence legal frameworks, particularly around vaccination? Answer. The advent of smallpox vaccination led to compulsory vaccination laws, sparking public resistance and landmark legal cases. In the U.S., the Supreme Court case Jacobson v. Massachusetts, 1905, upheld the state's right to enforce compulsory vaccination, a ruling that continues to influence public health law. Question. How did smallpox impact religious beliefs and practices? Answer. In some cultures, smallpox was personified as a deity or demon, and rituals were performed to appease or ward off the disease. The success of vaccination also led to debates within religious communities about the ethics of vaccination and its compatibility with religious doctrine. Question. What are the lingering cultural memories of smallpox in different societies? Answer. The fear and devastation wrought by smallpox have left lasting impressions in literature, art, folklore, and cultural memory. For example, smallpox scars were considered marks of survival and became symbolic in some cultures. Question. How was smallpox used in early biological warfare? Answer. Smallpox was intentionally spread among enemy populations during conflicts like the French and Indian War. This early form of biological warfare had profound effects on the course of these conflicts. Question. How did smallpox shape global health initiatives and international cooperation? Answer. The successful eradication of smallpox marked a milestone in global health cooperation. The campaign brought together countries, organizations, and individuals in an unprecedented effort, setting a precedent for future global health initiatives. Further information. For an in-depth exploration of the historical and cultural impact of smallpox, readers can consult academic historical works, public health records, and cultural studies from reputable institutions and authors. The intriguing case of polydactyly. Why do some people have extra fingers or toes? Patient presentation. A 4-month-old male infant was brought into the clinic by his parents for a scheduled well-child visit. The child was born with 6 fingers on his left hand, a condition identified as polydactyly at birth. The extra digit is fully formed and functional. Family history reveals that the paternal grandfather also had polydactyly. Inheritance. Polydactyly can be inherited in an autosomal dominant manner, although it can also occur sporadically. In this case, the condition appears to have been passed down from the paternal side of the family. Statistics. Males and females are equally affected. Surgical removal is the most common treatment and is usually performed in infancy or early childhood to ensure the least amount of psychological impact. The procedure's complexity depends on the extra digit's anatomical structure. 1. Famous figures. Hollywood actor Gemma Arterton was born with an extra finger on each hand. Historical importance. Anne Boleyn, the second wife of Henry VIII, was rumored to have polydactyly, which some considered a sign of witchcraft at the time. Polydactyly, the presence of extra digits on the hands or feet, has garnered varying degrees of cultural and historical relevance. Here are some key points. Cultural significance. In some cultures, polydactyly is considered a sign of good fortune or special powers. During the European witch trials, polydactyly was sometimes viewed as a sign of witchcraft. Anne Boleyn, the second wife of King Henry VIII, was rumored to have had an extra finger, although historical evidence is inconclusive. Tribal beliefs. In some indigenous cultures, individuals with polydactyly were considered to have heightened spiritual powers or were designated for specific societal roles based on this unique characteristic. Medical history. Polydactyly is one of the oldest congenital conditions known to medicine, with cases documented in ancient Egyptian scrolls and in early medical literature. Myths and legends. In certain mythologies, gods or mythological creatures are depicted with extra limbs or digits, though these are not always in line with human polydactyly. Legal and ethical issues. The surgical removal of extra digits is sometimes the subject of ethical debates, especially when the procedure is carried out on infants for aesthetic reasons rather than medical necessity. Influence on art. In art history, figures with extra digits have been painted or sculpted, either as a symbol of something greater or as a direct representation of someone known to the artist to have the condition. Superstitions. Even in contemporary society, superstitions about polydactyly persist, ranging from good luck charms to ill omens. Museum exhibits. Specimens of polydactyly have been displayed in medical museums, often to illustrate the range of human anatomical diversity. Summary. Polydactyly is a congenital condition that can be inherited or occur sporadically. Its cultural and historical relevance make it an intriguing subject for both medical professionals and laypeople alike. For further information. For more detailed information on polydactyly, please refer to the latest medical publications, case studies, and guidelines from trusted health organizations. The Spanish flu of 1918, unveiling facts for medical professionals, historians, and the curious public. Misleading name. The Spanish flu didn't originate in Spain. The name came from the extensive coverage in Spanish media, as Spain was neutral in World War I and had no wartime censorship on reporting the disease. Worldwide impact. It's estimated that about 1/3 of the global population was infected with this strain of H1N1 influenza, resulting in approximately 50 million deaths worldwide. Deadly to young adults. Unlike most flu strains that typically affect the very young or the elderly, the Spanish flu was particularly lethal to young adults aged 20 to 40. Rapid spread. In the absence of vaccines and antiviral medications, the Spanish flu spread quickly, with the deadliest wave occurring in the fall of 1918. Effect on World War I. The flu infected soldiers and civilians alike, potentially altering the course of battles and negotiations during World War I. Symptom severity. Some patients died within hours of showing symptoms, and their skin would turn blue, leading to the term, blue death. Economic impact. The pandemic caused significant economic disruption, affecting businesses, trade, and daily life. Limited healthcare resources. Hospitals were overwhelmed, leading to a shortage of medical professionals and supplies. Influence on public health. The pandemic shaped public health responses and policies, leading to the development of better equipped health departments and the establishment of the World Health Organization. Animal origins. The virus likely originated in birds and may have jumped to humans through an intermediate host. Unexpected resurgence. Samples of the virus were recovered from the frozen remains of flu victims, leading to renewed research into this particular strain. Lasting cultural impact. The Spanish flu left a mark on art, literature, and music, reflecting society's grappling with the immense tragedy. The Spanish flu of 1918 remains a profound lesson in the global impact of infectious diseases. Its influence can be seen across various facets of life, from medicine and economics to culture and history. Understanding this pandemic helps inform our response to contemporary health challenges and underscores the continued importance of vigilance, preparedness, and global cooperation. Tuberculosis unveiled. Uncommon facts for medical professionals, historians, and curious minds. Consumptive chic. In the 19th century, the pale and emaciated appearance caused by TB became a fashionable aesthetic, known as consumptive chic. This influenced beauty standards of the time. TB tourism. In the early 20th century, patients with TB would often travel to sanatoria in mountainous or dry regions, believing that the climate could cure the disease. Vampires and TB. Some historians believe that the folklore around vampires may have arisen from misunderstandings about TB. Symptoms like pallor and blood from coughing could have contributed to these myths. A connection to chocolate. Swiss chocolate maker Henri Nestlé originally created powdered milk as a way to combat infant mortality caused by milk-borne TB and other diseases. BCG scar identification. People vaccinated with Bacillus calmette-guerin, BCG, often have a distinctive scar on their upper arm, which sometimes is used as proof of vaccination in countries where TB is prevalent. Historic writings on TB. TB was known in ancient times and was referred to as phthisis in Greek writings. It's one of the oldest diseases known to humanity. Impact on opera and art. TB influenced several famous operas and paintings. For example, Violetta, the protagonist in Verdi's La Traviata, suffers from TB, and the disease is depicted in paintings by Edvard Munch. World War I impact. During World War I, more British soldiers were discharged due to TB than battle wounds. Animal infections. TB doesn't only affect humans, it can also infect animals such as cows and deer. Bovine TB led to regulations and practices in milk pasteurization. Influence on architecture. TB shaped modern architecture, with emphasis on sunlight and fresh air in building design. The sanatorium movement promoted these architectural principles. Political legacy. Nelson Mandela suffered from TB during his imprisonment, and the disease later influenced his public health policies. A global crisis. Despite being curable, TB remains one of the top 10 causes of death worldwide, highlighting challenges in diagnostics, treatment, and access to care. These facts underscore the complex and multifaceted impact of TB, not just as a medical issue but as a cultural, historical, and societal phenomenon. The disease's influence stretches far beyond the clinic, permeating art, architecture, politics, and even mythology. Understanding basilar artery stroke. Symptoms, affected areas, and diagnosis and insight for medical students, nursing students, and other healthcare students. Question: what are the common symptoms of a basilar artery stroke? Answer: diplopia, quadriparesis, alteration of consciousness, memory impairment, and visual field deficits. Question: which areas of the brain are typically affected in a basilar artery stroke? Answer: pons, midbrain, occipital cortex, and medial temporal lobes. Question: how is a basilar artery stroke diagnosed? Answer: diagnosis often involves a combination of clinical assessment, CT or MRI imaging, and angiography. Question: what are some potential causes of basilar artery stroke? Answer: atherosclerosis, embolism, vasculitis, and vertebral artery dissection. Question: what are the treatment options for a basilar artery stroke? Answer: treatment may include anticoagulation therapy, thrombolysis, mechanical thrombectomy, and supportive care. Question: how does basilar artery stroke differ from other types of stroke? Answer: basilar artery stroke specifically affects the brain's posterior circulation and can result in unique clinical symptoms, such as locked-in syndrome. Question: what are the long-term outcomes for patients with basilar artery stroke? Answer: outcomes vary and can range from complete recovery to severe disability or death. Question: how does basilar artery occlusion present on an MRI? Answer: basilar artery occlusion may appear as a hyperdense artery sign or an area of restricted diffusion in the affected regions of the brain. Question: what are the risk factors for basilar artery stroke? Answer: hypertension, smoking, hyperlipidemia, diabetes mellitus, and certain genetic factors. Question: how are patients with basilar artery stroke typically managed in the acute phase? Answer: immediate medical stabilization, assessment for thrombolysis or thrombectomy, and supportive care including airway management if necessary. Further information: for a comprehensive and detailed understanding of basilar artery stroke, including the latest research findings, diagnostic techniques, treatment options, and patient care guidelines, medical professionals are encouraged to refer to peer-reviewed medical journals, authoritative medical textbooks, and reputable online resources such as medical university websites and professional healthcare organizations. Continuing medical education, CME, courses and seminars may also provide valuable insights and hands-on experience. Understanding cancer statistics, an insight for medical students, nursing students, and other healthcare professionals. Questions and answers. Question: what is the most commonly diagnosed cancer among men worldwide? Answer: prostate cancer is the most commonly diagnosed cancer among men worldwide. Question: what is the most common cause of cancer-related deaths in women globally? Answer: breast cancer is the leading cause of cancer-related deaths in women globally. Question: which country has the highest incidence rate of cancer? Answer: as of recent data, Australia has one of the highest cancer incidence rates globally. Question: what are the 5-year survival rates for stage 1 and stage 4 lung cancer? Answer: the 5-year survival rate for stage 1 lung cancer is about 60–80%, while for stage 4, it's less than 10%. Question: how has the overall cancer death rate changed over the past few decades? Answer: the overall cancer death rate has declined by approximately 30% over the past 3 decades in many developed countries. Question: how many new cancer cases are expected to be diagnosed in the United States in 2021? Answer: in 2021, it's estimated that there will be around 1.9 million new cancer cases diagnosed in the United States. Question: which cancer has the lowest survival rate? Answer: pancreatic cancer has one of the lowest 5-year survival rates, around 10%. Question: how many people are living with cancer worldwide? Answer: as of recent data, over 43 million people are living with cancer worldwide. Question: what percentage of cancer is attributed to genetic factors? Answer: genetic factors are responsible for about 5–10% of all cancer cases. Question: what are the 3 leading cancers in children? Answer: the 3 most common cancers in children are leukemia, brain tumors, and lymphomas. Question: what is the estimated global economic impact of cancer? Answer: the estimated global economic impact of cancer is around $1.16 trillion annually. Question: how does smoking contribute to cancer statistics? Answer: smoking is responsible for about 30% of all cancer deaths and is the leading cause of lung cancer. For further information, please consult authoritative sources such as the World Health Organization, American Cancer Society, or National Cancer Institute. Case study: understanding hypothyroidism due to thyroid failure in Hashimoto's thyroiditis, autoimmune thyroiditis. Answers. Patient presentation. Patient, 45-year-old male. Chief complaint: fatigue, unexplained weight gain, and sensitivity to cold. Medical history: family history of autoimmune diseases, especially Hashimoto's thyroiditis. Exam findings: paleness, dry skin, puffiness around the face, and elevated BMI. Lab results: TSH, 12 μ/L, high. Free T4 to 0.6 nanograms DL, low. Positive anti-TPO antibodies. Key statistics and insights on Hashimoto's thyroiditis. High prevalence. Hashimoto's thyroiditis is the most common cause of hypothyroidism in the U.S., affecting approximately 5 out of 100 people. Autoimmune basis. Autoimmune thyroiditis, specifically Hashimoto's thyroiditis, targets the thyroid gland, leading to its destruction. Hypothyroidism due to thyroid failure. Autoimmune thyroiditis often culminates in thyroid failure, leading to hypothyroidism as seen in this case. Risk factors. Family history of autoimmune diseases, such as Hashimoto's thyroiditis, increases the risk of developing hypothyroidism due to thyroid failure. Diagnosis. Elevated TSH levels, low free T4, and presence of anti-TPO antibodies are key indicators for diagnosis. Treatment. Thyroid hormone replacement therapy is the gold standard for treating hypothyroidism due to thyroid failure. Regular monitoring. Periodic TSH and free T4 level checks are essential to monitor treatment effectiveness. Impact on quality of life. Hypothyroidism can significantly impact the quality of life if left untreated, making early detection vital. Autoimmune thyroiditis answers. This case provides insights into the multifaceted aspects of managing hypothyroidism due to thyroid failure, particularly in Hashimoto's thyroiditis. Summary. This case study aims to provide autoimmune thyroiditis answers by focusing on hypothyroidism due to thyroid failure in the context of Hashimoto's thyroiditis. The autoimmune destruction of the thyroid gland is a principal contributor to hypothyroidism, confirmed through elevated TSH, low free T4, and presence of anti-TPO antibodies. Treatment with thyroid hormone replacement therapy showed promising results. For more information, for a comprehensive understanding of Hashimoto's thyroiditis and hypothyroidism due to thyroid failure, consult medical databases like PubMed, clinical guidelines, and specialized endocrinology textbooks. What causes uremic platelet dysfunction and how can it be diagnosed? Uremic platelet dysfunction is mainly induced by advanced kidney disease and leads to a reduced formation of thromboxane A2 and increased platelet nitric oxide synthesis. These changes result in diminished platelet adherence to blood vessels, making patients more susceptible to bleeding. Clinical scenario. Consider a 65-year-old male with stage 4 chronic kidney disease who comes in with unexplained bruising and frequent nosebleeds. Although coagulation tests are normal, a platelet aggregation study confirms uremic platelet dysfunction due to his advanced kidney disease. Immediate action is taken to manage his kidney condition and reduce his risk of severe bleeding complications. Facts. 1. Thromboxane A2 is a critical factor in vasoconstriction and platelet aggregation. 2. Nitric oxide serves as a vasodilator and inhibits platelet aggregation. 3. The condition is often seen in later stages of chronic kidney disease. 4. Standard coagulation tests like PT and APTT may be normal, masking the dysfunction. 5. Platelet function tests such as platelet aggregation studies can help in the diagnosis. 6. Management usually focuses on treating the underlying kidney disease. 7. Hemodialysis can bring partial improvement in platelet function. How to test for uremic platelet dysfunction. Testing may involve platelet function tests like platelet aggregation studies, which are more sensitive in detecting this condition than standard coagulation tests. Additional diagnostic methods may include bleeding time, clot retraction, and flow cytometry tests to assess platelet activation markers. Where to find more information? For more comprehensive details on this topic, please visit reputable medical databases like PubMed or consult nephrology textbooks. Westermarck sign in pulmonary embolism. A radiologic indicator, understanding and historical relevance. Question: what is Westermarck sign? How is it visualized on a chest radiograph? And what is its clinical significance and historical relevance in the diagnosis and understanding of pulmonary embolism? Information. Westermarck sign refers to a hyperlucent area of the lung on a chest radiograph. This sign is classically associated with a pulmonary embolus, where it occurs distal to the embolus due to decreased pulmonary artery flow. It is one of the radiological signs that can be observed in patients with suspected pulmonary embolism, PE. Facts. Westermarck sign is named after the Swedish physician Nils Johan Hugo Westermarck, who first described it in 1938. This sign has historical importance as one of the early radiological signs used to suggest the diagnosis of PE before the advent of more advanced imaging techniques. It is not consistently present in all cases of PE and may be observed in only a minority of patients. Westermarck sign is more commonly seen in large or central PE. The hyperlucent area represents decreased blood volume due to obstruction of the pulmonary artery. It is not specific to PE and can be seen in other conditions that cause decreased blood flow in the pulmonary vessels. Statistics. Pulmonary embolism affects up to 1 in 1,000 people in the United States annually. The sensitivity and specificity of Westermarck's sign for PE are relatively low, making it an ancillary finding rather than a definitive diagnostic tool. Imaging studies such as CT pulmonary angiography have largely supplanted chest radiography in the diagnosis of PE. Historical relevance. Westermarck's sign, identified over 80 years ago, played a significant role in the early radiological diagnosis of PE. Its recognition paved the way for further understanding of the disease and prompted the development of more accurate diagnostic methods. Summary. Westermarck's sign, although a recognized radiological feature of pulmonary embolism, is neither highly sensitive nor specific. Its historical significance and presence may suggest the diagnosis of PE, particularly in the right clinical context, but it is generally considered an adjunct to more definitive diagnostic modalities. Associated diseases: pulmonary embolism, chronic thromboembolic pulmonary hypertension, pulmonary artery obstruction. Where to find more information? For further exploration, consult radiology textbooks, reputable medical imaging websites, guidelines from pulmonary and radiology professional societies, and peer-reviewed journal articles on pulmonary embolism diagnosis.
What is Capgras syndrome? Capgras syndrome, named after the French psychiatrist Joseph Capgras, is a rare and fascinating psychiatric disorder characterized by a distinctive delusion. Affected individuals firmly and falsely believe that someone they know, often a close family member or friend, has been replaced by an imposter or duplicate, leading to a profound sense of deception and detachment. The historical context of Capgras syndrome can be traced back to the early 1920s, when the pioneering work of Joseph Capgras and his colleague Jean Rébu-Lachaud first documented this unusual condition. These early observations provided the foundation for understanding the intricacies of this perplexing disorder within the field of psychiatry. In a patient case, consider Sarah, a 34-year-old woman with no prior psychiatric history. Sarah developed Capgras syndrome, a condition that left her firmly convinced that her husband had been replaced by an imposter who closely mimicked his appearance and mannerisms. This delusion caused immense distress, creating strains within her relationship and her overall emotional well-being. Capgras syndrome remains exceedingly rare in the realm of psychiatric disorders, and as such, comprehensive statistics regarding its prevalence and incidence are notably elusive due to its infrequent occurrence. Capgras syndrome is often associated with underlying psychiatric conditions, such as schizophrenia, dementia, or specific brain injuries. Treatment typically encompasses a combination of psychotherapy and medication, predominantly antipsychotic drugs, to alleviate distressing symptoms. The precise cause of Capgras syndrome remains partially understood, but is believed to involve intricate interactions within the neural pathways of the brain. For comprehensive insights into Capgras syndrome, covering its symptoms, diagnostic criteria, and diverse treatment options, individuals are strongly encouraged to consult with mental health professionals or reputable medical sources, such as the National Institute of Mental Health, NIMH, or the American Psychiatric Association, APA website. Seeking guidance and support from qualified healthcare providers is paramount to ensure accurate diagnosis and personalized care for those affected by this intriguing psychiatric condition. What is Cotard syndrome? Walking corpse syndrome. Cotard syndrome, commonly known as walking corpse syndrome, is an exceptionally rare psychiatric disorder characterized by an extraordinary belief in which affected individuals are convinced that they are deceased, non-existent, or have lost their internal organs. This unique condition traces its origins to the late 19th century and is named after the French neurologist Jules Cotard, who provided the first descriptions of the syndrome. Patient case: understanding Cotard syndrome. Consider the case of Emily, a 42-year-old woman previously diagnosed with major depressive disorder. Emily developed Cotard syndrome, manifesting as a firm conviction that she had passed away and her body was decaying. She consistently referred to herself as a walking corpse and expressed the loss of her internal organs. These distressing symptoms significantly disrupted her daily life. It is good to remember that Cotard's syndrome is an exceptionally rare condition, with only a limited number of documented cases reported worldwide. Due to its extreme rarity, precise statistics regarding its prevalence and incidence are not well established. Cotard's syndrome often co-occurs with underlying psychiatric disorders, such as major depressive disorder or schizophrenia. Treatment typically involves a multifaceted approach encompassing psychotherapy, medication, e.g., antidepressants or antipsychotics, and supportive care. Although the precise cause of Cotard's syndrome remains not entirely understood, it is believed to involve intricate neurological and psychological factors. For comprehensive insights into Cotard's syndrome, including its symptoms, historical context, diagnosis, and treatment options, individuals are encouraged to consult mental health professionals or reputable medical sources such as the National Institute of Mental Health or the American Psychiatric Association website. Seeking guidance from qualified healthcare providers is crucial for accurate diagnosis and personalized care.
Understanding dilantin and cytochrome P450 interactions. A guide for medical students, nursing students, and other healthcare students. Questions and answers about cytochrome P450 and dilantin. Question: what is dilantin, and what is its primary medical use? Answer: dilantin, or phenytoin, is an antiepileptic medication mainly used to control seizures. Question: what is the cytochrome P450 system? Answer: cytochrome P450 is a group of enzymes responsible for metabolizing many drugs and other xenobiotics. They are heme thiolate monooxygenases found in the liver and other tissues. These enzymes catalyze the oxidation of organic substances, such as pharmaceuticals, and play an essential role in the metabolism, synthesis, and breakdown of various molecules and chemicals within the body. Question: how does dilantin interact with the cytochrome P450 enzyme system? Answer: dilantin induces the cytochrome P450 enzyme system, which can increase the metabolism of other antiepileptic drugs, oral contraceptives, Coumadin, quinidine, doxycycline, cyclosporin, levodopa, and many other medications. Question: why is the interaction between dilantin and the cytochrome P450 system significant? Answer: the interaction may alter the blood levels and efficacy of various medications metabolized by the P450 system, potentially leading to therapeutic failure or increased toxicity. Question: how should clinicians manage patients taking dilantin and other medications metabolized by the cytochrome P450 system? Answer: careful monitoring of medication levels, consideration of potential interactions, and appropriate dose adjustments are key to managing these patients effectively. Question: what are the potential consequences of failing to recognize the interaction between dilantin and the cytochrome P450 system? Answer: failing to recognize this interaction can lead to unexpected changes in drug efficacy or toxicity, possibly resulting in uncontrolled seizures, increased side effects, or other adverse clinical outcomes. For further information, please refer to reputable medical textbooks, peer-reviewed journal articles, or authoritative online resources like Medline Plus, FDA websites, or university medical centers to delve deeper into the interaction between dilantin and the cytochrome P450 system, and its implications in clinical practice. What are symptoms of right posterior cerebral artery stroke? Patients suffering from a right posterior cerebral artery (PCA) stroke commonly exhibit specific symptoms such as left homonymous hemianopsia and unformed visual hallucinations. The occipital cortex, supplied by the PCA, is generally affected, leading to these distinctive visual impairments. The reason a right PCA stroke affects the left visual field is intricately linked with the anatomy of the visual pathway. Once light enters the eyes, it is converted into neural signals that travel through the optic nerves. These signals cross at the optic chiasm, leading to the right occipital cortex processing signals representing the left visual field and vice versa. Therefore, a stroke in the right PCA would naturally affect the left visual field. In the case of a right PCA stroke, the blood supply to the right occipital lobe is compromised, affecting the portion of the visual pathway that processes information coming from the left visual field. Patients commonly experience left homonymous hemianopsia, where vision in the left half of both eyes is lost. Additionally, unformed visual hallucinations may occur, such as random flashes or spots of light, due to the lack of sensory input to the affected brain regions. Stroke remains the fifth leading cause of death in the United States, affecting around 795,000 people each year. Right PCA strokes, although less common than strokes in the anterior circulation, can result in severe and lasting disability. These make up a substantial portion of the overall stroke cases, emphasizing their clinical importance. Besides MRI or CT scans that are standard for diagnosing any stroke, visual field tests are also employed to assess the extent of vision loss. Electroencephalograms, EEGs, can be beneficial in evaluating the unformed visual hallucinations that may be experienced by the patient. Early diagnosis and treatment are crucial in minimizing the effects of a PCA stroke. Therapeutic options may include anticoagulant medications, surgical interventions, and rehabilitative therapies aimed at improving lost functions. For those interested in diving deeper into the subject, a variety of peer-reviewed articles and extensive case studies are available. This literature offers a more detailed understanding of right PCA stroke symptoms, as well as advanced diagnostic and treatment options.
What are the common side effects of tamsulosin, Flomax? Tamsulosin is a medication primarily used to treat the symptoms of an enlarged prostate, benign prostatic hyperplasia or BPH. It is known by several brand names including Flomax, Alna, and Contiflo. While it can be an effective treatment, it is essential to be aware of potential side effects. Tamsulosin is generally well tolerated, but like any medication, it can cause side effects. The most common side effect associated with tamsulosin is orthostatic hypotension. Orthostatic hypotension occurs in approximately 7% of patients receiving tamsulosin, Flomax. Orthostatic hypotension after the first dose often occurs approximately 4 hours after taking the medication. This condition involves a sudden drop in blood pressure when transitioning from sitting or lying down to standing. These symptoms often occur when transitioning from sitting to standing position. Approximately 7% of patients may experience orthostatic hypotension after the first dose of tamsulosin. The incidence of orthostatic hypotension may decrease with continued use of the medication. Taking tamsulosin on an empty stomach can lead to increased medication levels compared to taking it with a full stomach. It is generally recommended to take it approximately 30 minutes after the same meal each day. This helps maintain consistent medication levels in your body, which can improve its effectiveness in managing the symptoms of an enlarged prostate, benign prostatic hyperplasia or BPH. For more detailed information on tamsulosin, its side effects, and usage guidelines, consult your healthcare provider or refer to reputable medical resources, such as the prescribing information provided with the medication or medical websites like Medline Plus or Mayo Clinic. Always follow your healthcare provider's recommendations and report any concerning side effects promptly.
What are the 4 types of malaria? An in-depth exploration for medical students and healthcare professionals. Question: what is the most deadly species of Plasmodium responsible for malaria? Answer: Plasmodium falciparum is the most dangerous type and is responsible for the majority of malaria-related deaths worldwide. Question: which Plasmodium species causes tertian fever in malaria? Answer: Plasmodium vivax and Plasmodium ovale cause tertian fever, with symptoms recurring every other day. Question: which type of malaria can remain dormant in the liver for extended periods? Answer: Plasmodium vivax can remain dormant in the liver and can relapse years after the initial infection. Question: what is unique about the life cycle of Plasmodium malariae? Answer: Plasmodium malariae has a 3-day life cycle, causing quartan fever with symptoms recurring every 3rd day. Question: how is Plasmodium ovale typically diagnosed? Answer: Plasmodium ovale is typically diagnosed through microscopic examination of blood films, as well as rapid diagnostic tests. Question: which Plasmodium species is most common in sub-Saharan Africa? Answer: Plasmodium falciparum is most common in sub-Saharan Africa. Question: how are the different types of Plasmodium transmitted? Answer: all 4 types of Plasmodium are transmitted through the bite of an infected female Anopheles mosquito. Question: what are some common prevention methods for malaria? Answer: prevention methods include mosquito netting, insect repellent, proper clothing, and antimalarial medications. Question: what are the typical symptoms of a malaria infection? Answer: typical symptoms include fever, chills, sweating, headaches, nausea, body aches, and in severe cases, coma or death. Question: which type of malaria is known for its prolonged incubation period? Answer: Plasmodium malariae has a prolonged incubation period, often taking weeks to manifest symptoms. Question: How does resistance to antimalarial drugs impact the treatment of malaria? Answer. Resistance, especially in Plasmodium falciparum, can make treatment more difficult, necessitating the use of combination therapies. Question. What are the key complications of malaria? Answer. Complications include anemia, respiratory distress, cerebral malaria, kidney failure, and death. Further information. To explore more details, statistics, and medical insights into the types of malaria, please refer to reputable sources such as the World Health Organization, WHO, or Centers for Disease Control and Prevention, CDC, websites. What are the cardiac risks associated with anthracycline chemotherapy? Doxorubicin, daunorubicin, epirubicin, and idarubicin are commonly used anthracycline chemotherapies. Acute reactions. Patients can experience acute anthracycline-related cardiac toxicity soon after the onset of treatment. These acute reactions manifest as arrhythmias, pericarditis, myocarditis, and conduction abnormalities and are not dose-related. The incidence of acute toxicity from anthracycline-based chemotherapy like adriamycin, doxorubicin, varies, but acute cardiac events are relatively rare. Acute cardiac toxicity, which can include arrhythmias, pericarditis, and myocarditis, has been reported to occur in less than 1% to around 2% of patients, depending on the study and the population being examined. Chronic toxicity. The risk of chronic cardiac toxicity is generally considered acceptable at cumulative doses below a commonly cited threshold. Dose dependency. Acute cardiac toxicity is not dose-related, whereas chronic toxicity is dose-dependent. Patient scenario. A middle-aged female undergoing chemotherapy with adriamycin presented with arrhythmias and was found to have acute cardiac toxicity within a few days of treatment initiation. The risk of chronic cardiac toxicity from adriamycin, doxorubicin, is known to increase with cumulative dosage. Although the risk varies between individuals and can be influenced by other factors like previous radiation therapy and pre-existing cardiac conditions, cardiac toxicity is generally considered a significant risk when the cumulative dose approaches or exceeds 400,550 mg per square meter. Statistics. A small percentage of patients receiving anthracyclines will experience some form of cardiac toxicity. The risk increases significantly with higher cumulative doses. Facts. Radiation recall. Anthracyclines can trigger radiation recall on the skin. Urine discoloration. Anthracyclines can change the color of the urine to a reddish-orange hue. Myelosuppression. Anthracyclines can result in myelosuppression, leading to a decrease in the body's ability to fight infections. Alopecia. Hair loss is another common side effect of anthracycline therapy. GI symptoms. Gastrointestinal symptoms such as nausea, vomiting, and diarrhea are also common side effects of anthracyclines. Tissue necrosis. Extravasation can lead to severe tissue necrosis if anthracyclines infiltrate the surrounding tissues. For more information on this subject, consult reliable medical journals, Oncological Society guidelines, or PubMed. What causes hypercalcemia? Unraveling the Complex Mechanisms, a comprehensive guide for medical students, nursing students, and medical professionals. Questions and answers. Question. What physiological mechanism is behind the hypercalcemia seen in hyperparathyroidism? Answer. Hyperparathyroidism leads to the excessive production of parathyroid hormone, increasing calcium reabsorption in the kidneys and calcium release from bones, thus causing hypercalcemia. Question. Name 2 malignancies that can lead to hypercalcemia. How do they achieve this? Answer. Lung cancer and breast cancer may lead to hypercalcemia through bone involvement and destruction or by secreting parathyroid hormone-related protein, PTHrP, which mimics the action of PTH. Question. How can excessive vitamin D supplementation lead to hypercalcemia? Answer. Vitamin D enhances calcium absorption from the gastrointestinal tract, leading to increased serum calcium levels. Excessive supplementation can thus cause hypercalcemia. Question. What are the clinical manifestations of acute hypercalcemia? Answer. Acute hypercalcemia may present with fatigue, confusion, frequent urination, muscle weakness, constipation, and cardiac arrhythmias. Question. How does Paget's disease contribute to hypercalcemia? Answer. Paget's disease disrupts normal bone remodeling, increasing bone resorption, which may lead to hypercalcemia. Question. Describe the connection between immobility and hypercalcemia. Answer. Immobility leads to bone demineralization and calcium release into the bloodstream, resulting in hypercalcemia. Question. What are some diagnostic tests used to evaluate hypercalcemia? Answer. Diagnostic tests for hypercalcemia include serum calcium, serum PTH, vitamin D levels, kidney function tests, and imaging studies to evaluate potential underlying causes. Question. How does Zollinger-Ellison syndrome contribute to hypercalcemia? Answer. Zollinger-Ellison syndrome leads to increased gastric acid production, which can cause calcium release from bones and hypercalcemia. Question. What are the potential renal effects of hypercalcemia? Answer. Hypercalcemia can lead to nephrocalcinosis, kidney stones, and renal impairment. Question. How does milk alkali syndrome cause hypercalcemia? Answer. Milk alkali syndrome is caused by excessive intake of calcium and absorbable alkali, resulting in increased blood calcium levels. Question. Explain the relationship between Addison's disease and hypercalcemia. Answer. Addison's disease leads to decreased aldosterone production, reducing renal excretion of calcium, and possibly resulting in hypercalcemia. Question. How can sarcoidosis contribute to hypercalcemia? Answer. Sarcoidosis may lead to increased conversion of vitamin D to its active form in the lungs, enhancing calcium absorption and causing hypercalcemia. Further information. For comprehensive insights into hypercalcemia, including management strategies, refer to authoritative medical texts and online medical resources. What causes hypercoagulable states in nephrotic syndrome? Mechanisms and implications for medical students, nursing students, and medical professionals. Question. What is nephrotic syndrome, and how is it related to hypercoagulable states? Answer. Nephrotic syndrome is characterized by significant proteinuria, hypoalbuminemia, edema, and hyperlipidemia. It leads to hypercoagulable states through the loss of anticoagulants in the urine and the accumulation of clotting factors in the blood plasma. Question. What causes the loss of anticoagulants like AT3 and alpha-2 antitrypsin in nephrotic syndrome? Answer. In nephrotic syndrome, the glomerular filter becomes more permeable to proteins, leading to the loss of anticoagulants such as AT3 and alpha-2 antitrypsin in the urine, which can contribute to a hypercoagulable state. Question. How do clotting factors like factor VIII, von Willebrand factor, fibrinogen, factor V, and factor VII accumulate in the blood plasma in nephrotic syndrome? Answer. The liver increases the synthesis of these clotting factors as a response to hypoalbuminemia in nephrotic syndrome. Additionally, the urinary loss of anticoagulants leads to reduced inhibition of these factors, causing them to accumulate in the blood plasma. Question. What is von Willebrand factor, and how does its accumulation contribute to clot formation in nephrotic syndrome? Answer. Von Willebrand factor is a glycoprotein that mediates platelet adhesion and aggregation. Its accumulation in nephrotic syndrome, due to increased synthesis and reduced inhibition, enhances clot formation and contributes to a hypercoagulable state. Question. How does fibrinogen contribute to the hypercoagulable state in nephrotic syndrome? Answer. Fibrinogen is a soluble plasma protein that is converted into fibrin during clotting. Its accumulation in nephrotic syndrome, due to the same mechanisms as von Willebrand factor, leads to increased clotting in a hypercoagulable state. Question. What therapeutic interventions might be necessary to manage hypercoagulable states in nephrotic syndrome? Answer. Interventions may include anticoagulant medications, monitoring of clotting factors, lifestyle modifications, and coordinated care with specialists to address both the underlying nephrotic syndrome and the associated hypercoagulable state. Question. Why is understanding the mechanisms of hypercoagulable states in nephrotic syndrome important for healthcare professionals? Answer. Understanding these mechanisms is crucial for the diagnosis, prevention, and management of thromboembolic events in patients with nephrotic syndrome, ultimately improving patient outcomes. Further information. The complex relationship between nephrotic syndrome and hypercoagulable states requires careful consideration by healthcare professionals. For more detailed information and clinical guidelines, consult specialized nephrology textbooks, research articles, or authoritative online sources. What does a serum osmolality of greater than 10 indicate? An exploration of causes and clinical implications for medical students, nursing students, and medical professionals. Question. What does a serum osmolality of greater than 10 indicate about the serum water per volume of the sample being measured? Answer. A serum osmolality of greater than 10 indicates decreased serum water per volume of the sample being measured. Question: how can hyperlipidemia affect serum osmolality? Answer: hyperlipidemia can contribute to a serum osmolality of greater than 10 by increasing the serum concentration of lipids, thus decreasing the serum water per volume of the sample. Question: how can hyperproteinemia affect serum osmolality? Answer: hyperproteinemia can contribute to a serum osmolality of greater than 10 by increasing the serum concentration of proteins, thereby decreasing the serum water per volume of the sample. Question: how can the presence of low molecular weight particles like mannitol affect serum osmolality? Answer: low molecular weight particles like mannitol can increase the serum concentration of solutes, leading to a serum osmolality of greater than 10. Question: what substances like methanol and ethylene glycol can lead to increased serum osmolality? Answer: substances like methanol and ethylene glycol can increase serum osmolality by contributing additional low molecular weight particles to the serum, resulting in a value of greater than 10. Question: how does ETOH, ethanol, affect serum osmolality? Answer: ethanol, ETOH, can contribute to increased serum osmolality by being a low molecular weight particle, leading to a serum osmolality of greater than 10. Question: what implications does a serum osmolality of greater than 10 have for clinical practice? Answer: a serum osmolality of greater than the 10th of may indicate underlying conditions such as hyperlipidemia or hyperproteinemia, or exposure to certain substances like mannitol or ethanol. Accurate diagnosis and targeted treatment can address the underlying cause. Question: how can para-aldehydes affect serum osmolality? Answer: para-aldehydes, being a low molecular weight particle, can contribute to increased serum osmolality, leading to a value of greater than 10. Further information: understanding the complexities of serum osmolality and the factors that can influence its value is vital for healthcare professionals. To delve deeper into this subject, consult medical textbooks, peer-reviewed journals, or authoritative online resources. What is pseudotumor cerebri? Pseudotumor cerebri, also commonly known as idiopathic intracranial hypertension, is a neurological disorder characterized by elevated intracranial pressure with no clear etiology. Despite the absence of a tumor, this condition exhibits symptoms similar to those seen in cases of brain tumors, such as headache, visual field defects, and papilledema. It's particularly prevalent among young, obese females, with statistical data indicating a prevalence rate of about 1:2 in 100,000 in the general population and a female-to-male ratio of 4:1. Why is it called pseudotumor cerebri? The term, pseudotumor cerebri, literally means false tumor of the brain, capturing the essence of the condition where symptoms mimic a brain tumor without an actual tumor being present. The modern term, idiopathic intracranial hypertension, better describes the condition as it denotes elevated intracranial pressure without a discernible cause. Accurate diagnosis is vital for effective management. The process often involves multiple steps. 1. Lumbar puncture. Measuring cerebrospinal fluid, CSF, pressure via lumbar puncture is often the first step. 2. Imaging studies, MRI or CT scans help to rule out other intracranial abnormalities. 3. Visual field testing, essential for assessing optic nerve function and potential damage. 4. Fundoscopic examination. This can reveal the presence of papilledema, which is a swelling of the optic disc due to increased intracranial pressure. Additional diagnostic tools. Other tests may include blood tests to rule out infectious causes or other systemic conditions. Sometimes, a cerebral venogram is performed to exclude venous sinus thrombosis as a possible cause. Statistics and prevalence. To reiterate, pseudotumor cerebri affects 1:2 in 100,000 individuals in the general population. However, in obese women aged 20–44, the incidence spikes to as high as 19 in 100,000. Further reading. For those interested in diving deeper into this subject, it is advisable to consult scientific literature such as the journal article, Idiopathic Intracranial Hypertension, Contemporary Understanding and Management, which provides valuable insights and the latest research findings in this field. What is Ondine's curse? Ondine's curse, formerly known as congenital central hypoventilation syndrome, CCHS, blends medical science and mythology. Known variably as Ondine's curse, or even Ondine curse in Hindi-speaking regions, this condition affects automatic control of breathing. Case presentation. Diagnosing Ondine's curse in a newborn. Initial presentation. Patient shows signs typical of Ondine's curse, such as cyanosis and irregular breathing. Diagnosis for Ondine's curse. Polysomnography and FOX2B gene mutations confirmed Ondine's curse. Treatment for Ondine's curse. Immediate respiratory support and tracheostomy initiated due to severity of Ondine's curse. Outcome. Lifelong ventilation, especially during sleep, is essential due to Ondine's curse. The mythology behind Ondine's curse. Ondine's curse in the medical context leads us to its mythological origins. Ondine, a nymph, cursed her unfaithful lover to forget to breathe if he ever fell asleep. A literal curse, giving the condition its name, Ondine's curse. Pronunciation of Ondine's curse varies, but its symptoms remain the same. Failure of automatic control of breathing. The meaning of Ondine's curse goes beyond its symptoms, delving into lifelong management and the pronounced impact on quality of life. Ondine curse is exceedingly rare, with an estimated incidence of 1 in 200,000 live births. Ondine's curse causes revolve around mutations in the FOX2B gene. The condition impacts the neural circuitry responsible for automatic breathing, a defining feature of Ondine's curse. The diagnosis of Ondine's curse in a clinical setting involves specific genetic testing and sleep studies. Treatment often includes a mix of ventilator support and tracheostomy for severe cases of Ondine's curse. Ondine curse causes lifelong challenges, including a lack of curative treatments. From its name pronounced as Ondine's curse, to its mythological and clinical definitions, this condition intrigues and challenges both the medical community and the general public. If you have a question about Ondine's curse, leave in comments and we will try to answer. What is SIADH and which chemotherapy drugs are associated with it? Syndrome of inappropriate antidiuretic hormone secretion, SIAD, is a medical condition that involves the excessive release of antidiuretic hormone. This leads to water retention and a condition called dilutional hyponatremia. The incidence of SIADH varies but is estimated to be between 2.5% and 4% in hospitalized patients. Among the triggers for SIADH, certain chemotherapy drugs stand out: cyclophosphamide, cisplatin, melphalan, ifosfamide, and the vinca alkaloids. Clinical scenario: consider a 58-year-old male diagnosed with lung cancer. He is on a treatment regimen that includes cisplatin. After his second cycle of chemotherapy, he begins to experience nausea, headache, and confusion. Laboratory tests confirm a decrease in sodium levels in the blood, and he is subsequently diagnosed with SIADH. The oncology team must now adjust his chemotherapy regimen to mitigate the risk of exacerbating the SIADH. Facts. 1. SIADH is most commonly observed in older adults. 2. Neurological symptoms can range from mild confusion to severe symptoms such as seizures or even coma. 3. Treatment often centers on fluid restriction and may also involve changing chemotherapy drugs if they are identified as the underlying cause. 4. Some cases of SIADH may resolve on their own, but chronic SIADH can result in neurologic issues ranging from cognitive deficits to seizures. 5. Other non-chemotherapy causes of SIADH include CNS disorders, pulmonary diseases, and certain medications like antipsychotics and antiepileptics. For more information about SIADH and its associations with chemotherapy, consult professional medical guidelines and journals. What is the lupus anticoagulant? Welcome to this comprehensive guide on the lupus anticoagulant. This perplexing antibody is linked to a heightened risk of thrombosis and presents both diagnostic and therapeutic challenges. Today, we'll delve into what lupus anticoagulant is, how it's identified, and the treatments available. Case presentation. Imagine a 37-year-old man who has been dealing with recurrent deep vein thrombosis, DVT. Even though he's been under standard anticoagulant treatment, he continues to develop clots. Blood tests reveal a prolonged APTT, leading to further assessment and a subsequent confirmation of lupus anticoagulant, warranting a change in his therapeutic plan. Key facts. 1. Lupus anticoagulant interferes with phospholipid-dependent coagulation tests, paradoxically increasing the risk of thrombosis. 2. Contrary to what the name implies, lupus anticoagulant can be found in people without lupus. 3. Diagnosis often includes identifying a prolonged activated partial thromboplastin time, APTT, and a mixing study can provide further confirmation. 4. Management often requires lifelong anticoagulation, especially in those with a history of thrombotic events. 5. Lupus anticoagulant can complicate pregnancies by increasing the risk of miscarriage and other adverse outcomes. The role of the mixing study. In the context of lupus anticoagulant, a mixing study is often performed to confirm the presence of an inhibitor like lupus anticoagulant. In a mixing study, the patient's plasma is mixed with normal plasma. If the APTT remains prolonged, it suggests the presence of an inhibitor, strengthening the diagnosis of lupus anticoagulant. Statistics. Around 1–5% of the general population may test positive for lupus anticoagulant. Various studies report different rates of lupus anticoagulant among people with unexplained thrombotic events. Up to 40% of patients with confirmed lupus anticoagulant could experience another thrombotic event within a decade. Why is it named lupus anticoagulant? The name, lupus anticoagulant, is somewhat misleading. Initially discovered in patients with lupus, it can be present in people with other conditions as well. Despite its name, which suggests an anticoagulant function, it raises the risk of clotting. Where to find more information? For additional information, you can refer to hematology-focused medical journals, seminars by experts in antiphospholipid syndrome, or reputable online resources specializing in coagulation disorders. What is the most common gynecologic malignancy? Endometrial cancer explained. A Q&A guide for medical students, nursing students, healthcare students. Essential knowledge for future healthcare professionals. Question: what is the most common gynecologic cancer, and what part of the uterus does it affect? Answer: endometrial cancer is the most common gynecologic cancer, affecting the inner lining of the uterus called the endometrium. Question: what are the histological subtypes of endometrial cancer, and which one is more common? Answer: the two main histological subtypes are endometrioid and serous carcinoma, with endometrioid being more common and accounting for about 80% of cases. Question: how do unopposed estrogen and obesity contribute to endometrial cancer? Answer: unopposed estrogen stimulates the endometrial lining, leading to hyperplasia and possibly malignancy. Obesity can lead to excess estrogen production, further increasing the risk. Question: what diagnostic modalities are used to evaluate abnormal uterine bleeding in suspected endometrial cancer? Answer: diagnostic modalities include transvaginal ultrasound, hysteroscopy, and endometrial biopsy. Question: describe the staging system for endometrial cancer. Answer: the FIGO system stages endometrial cancer from 1 to 4 based on the extent of tumor invasion and spread to lymph nodes and distant organs. Question: what surgical procedure is commonly performed in the treatment of endometrial cancer? Answer: a total hysterectomy with bilateral salpingo-oophorectomy is commonly performed, often along with lymph node dissection. Question: how does radiation therapy fit into the treatment of endometrial cancer? Answer: radiation therapy may be used postoperatively, as primary therapy for those unable to undergo surgery, or palliatively for symptom management. Question: how does Lynch syndrome relate to endometrial cancer? Answer: Lynch syndrome is a genetic condition that increases the risk of endometrial cancer, as well as other cancers like colorectal cancer. Question: what are the common signs and symptoms of advanced endometrial cancer? Answer: signs and symptoms may include pelvic pain, weight loss, bloating, changes in bowel or bladder habits, and metastatic symptoms such as jaundice or bone pain. Question: how does endometrial hyperplasia relate to endometrial cancer? Answer: endometrial hyperplasia is a precancerous condition characterized by the thickening of the endometrium. Certain types, especially with atypia, may progress to endometrial cancer. Question: what follow-up and surveillance are recommended for patients treated for endometrial cancer? Answer: follow-up usually includes regular physical and pelvic examinations, imaging as needed, and patient education to recognize signs of recurrence. For comprehensive information about endometrial cancer, including symptoms, diagnosis, treatments, and research, Medical students, nursing students, healthcare professionals, and others interested in this subject are encouraged to explore authoritative medical sources online. Reputable websites such as the American Cancer Society, the National Cancer Institute, World Health Organization, WHO, and prominent medical university websites are excellent starting points for accurate, up-to-date information about the most common gynecologic cancer. What is the PIK3CA mutation? How can the PIK3CA be targeted for treatment across different cancer types? Background: PIK3CA mutations are alterations in the PIK3CA gene that encodes the P110 alpha subunit of the PI3K enzyme. These mutations are often implicated in various types of cancers and are known to play a pivotal role in tumorigenesis, progression, and treatment resistance. Oncogenic role of PIK3CA. Mutations in PIK3CA are oncogenic, meaning they have the potential to cause cancer. They lead to an overactive PI3K, AKT, mTOR signaling pathway, which in turn stimulates cell growth, survival, and metabolic processes. Significance of targeting PIK3CA. Drugs targeting this mutation aim to inhibit the PI3K enzyme's activity, consequently inhibiting the downstream signaling that supports cancer growth. Medications that target PIK3CA. Alpelisib, Piqray, selectively inhibits the PI3K alpha isoform and is approved for advanced or metastatic breast cancer with a PIK3CA mutation. Idelalisib, Xidelug, inhibits PI3K delta and is used for certain types of blood cancer. Copanlisib, Alicopa, inhibits PI3K alpha and PI3K delta, approved for relapsed follicular B-cell non-Hodgkin lymphoma. Statistics. Breast cancer. Around 12% of women in the U.S. will develop invasive breast cancer, and approximately 15–40% of these cases have PIK3CA mutations. Colorectal cancer. About 10–20% of colorectal cancers have PIK3CA mutations. Can this enzyme be targeted across different cancer types? Yes, PIK3CA mutations are found in various cancer types, including breast cancer, colorectal cancer, and head and neck cancers. Targeting the PI3K enzyme encoded by PIK3CA can therefore offer a broad treatment strategy across multiple malignancies. Why do cancers have PIK3CA mutations? The PIK3CA mutations give cancer cells a survival advantage by upregulating pathways that support growth, impede apoptosis, and enhance metastasis. They offer cancer cells the attributes necessary for rapid evolution and resistance to treatments. How to treat cancer targeting this pathway? Drugs like alpelisib selectively inhibit the PI3K subunit associated with the PIK3CA mutation. This selective inhibition disrupts the cancer cell's growth and survival machinery, making it an effective targeted therapy for cancers with this specific mutation. Further reading. For a more in-depth understanding, consider reading scholarly articles such as PIK3CA mutations as a target in cancer therapy and PIK3CA mutation, a key target in the treatment of cancer. Why is prostate cancer one of the most common cancers in men? Prostate cancer is prevalent, with statistics showing that 1 in 6 men will be diagnosed with it at some point in their lives. In the United States, it is the second most common cancer among men, with an estimated 248,530 new cases expected in 2021. The development of prostate cancer is influenced by a myriad of factors, and in many cases, the exact cause remains unknown. However, certain risk factors have been identified. Age is a predominant factor, with men over 65 making up the majority of diagnosed cases. Genetics also plays a role. Having a family history of prostate cancer or other cancers can increase the risk. Hormonal factors, particularly the role of testosterone, are another area of focus in the medical community. Lifestyle and dietary choices, such as high consumption of red meat and high-fat dairy products, may contribute to the risk. Environmental exposures to certain chemicals or radiation have also been suggested as potential triggers. Diagnostic tools like the PSA test are crucial for early detection. Early-stage prostate cancer is usually treated with options ranging from watchful waiting to surgery, radiation, and hormone therapy. Some less discussed side effects of prostate cancer treatment include sexual dysfunction and urinary incontinence. Preventative measures. A healthy lifestyle is a key preventative measure for reducing the risk of prostate cancer. Regular exercise, a balanced diet high in fruits and vegetables, and maintaining a healthy weight can all be protective. According to the American Cancer Society, the 5-year survival rate for localized prostate cancer is nearly 100%, underscoring the importance of early detection. Consult trusted medical sources or your healthcare provider for more personalized advice. Facts. Prostate cancer is often asymptomatic in its early stages. The disease can metastasize to bones and lymph nodes. Diet and lifestyle, including high consumption of red meat or high-fat dairy, have been identified as potential risk factors. African American men are at higher risk for prostate cancer than men of other ethnicities. A high PSA level doesn't always indicate cancer. It can also be elevated due to infections, certain medications, or an enlarged prostate. For more information, you can visit the websites of organizations like the American Cancer Society or consult with your healthcare provider for personalized advice tailored to your situation. Why is the bleeding time test no longer used for presurgical screening? The bleeding time test has been largely sidelined due to several limitations, including its lack of sensitivity and specificity for detecting hemostatic issues. Cited studies like the 1998 research by Peterson P. Hayes Tay, Arkin C.F., et al. Confirm that it does not reliably predict surgical bleeding risk. The test's variable results, dependent on multiple factors such as technique and individual differences, also make it unreliable. It's invasive, requiring a skin cut and timed bleeding, leading to patient discomfort. More resource-efficient, accurate, and less invasive alternatives like prothrombin time, PT, and activated partial thromboplastin time, APTT, are now available for evaluating coagulation. Due to these drawbacks, the bleeding time test is not recommended for routine preoperative screening or other clinical evaluations. Why would you order a thrombin time test over PT or PTT? The thrombin time test is a specialized diagnostic tool that evaluates the conversion of fibrinogen to fibrin when thrombin is added to a plasma sample. While prothrombin time, PT, and activated partial thromboplastin time, APTT, are frequently used to assess the extrinsic and intrinsic pathways of the coagulation cascade respectively, the thrombin time test serves unique roles that these tests may not cover comprehensively. The thrombin time test is particularly sensitive to heparin and can be useful in detecting its presence in blood samples. This sensitivity can be crucial when you suspect heparin resistance or when very high doses of heparin are being used. Moreover, if you've neutralized heparin with protamine sulfate, the thrombin time test will help confirm that the heparin has been effectively neutralized. Additionally, the thrombin time test provides valuable information when direct thrombin inhibitors like argatroban or dabigatran are involved, information that PT and APTT may not accurately capture. The test can be particularly useful in complex coagulopathies, where multiple clotting inhibitors or multiple clotting factor deficiencies are present. For instance, in conditions like disseminated intravascular coagulation, DIC, or hemophilia with inhibitors, the thrombin time test can offer insights that are not readily apparent with PT or APTT. Such information can be invaluable for fine-tuning the treatment approach, and may even be life-saving in certain scenarios. Statistics show that the thrombin time test is not as commonly used as PT or APTT. However, its utility in specific clinical scenarios should not be overlooked. In such complex cases, the thrombin time test can offer data that could significantly influence treatment decisions. For more information, medical professionals are encouraged to consult reputable sources like PubMed, clinical guidelines, or specialized hematology textbooks focused on complex coagulopathy testing.